Good morning. If the people who are here can start making their way to their seats, it's 7:30. And we're going to begin as people continue to filter in. I'm Jeffrey Zonder from the Karmanos Cancer Institute, and I'd like to welcome you to Untangling Amyloidosis 2019. We're here live in Orlando, and this is also being live streamed. And it will also be available in an archived version to be reviewed at your convenience online following the event. I'd like to take care of a little bit of housekeeping first, and maybe the most important thing is to thank our sponsors who've helped make this possible. Wayne State University and the Karmanos Cancer Institute are accredited providers. Non-accredited providers include the Amyloidosis Foundation and amyloidosis support groups. And our corporate sponsors include Axia Therapeutics, Alnylam Pharmaceuticals, Calum Biosciences, Millennium Takeda, and Prothena Therapeutics Limited. So thank you so much for your support of this session. This is going to be an interactive session, and we have the sync system, which is going to be in use throughout ASH at different sessions. And on printed sheets on your table, there are instructions on how to log on, but you first start with the ASH Wi-Fi, and then you can open the browser and type in this address. It will ask you for your name and email address, and the reason for that is so that later you can be sent any notes that you take during the session at the end of the day. There are different icons that you'll see with this platform. The pencil is to take notes for yourself. The question mark and podium icon is to pose a question. And we will see, for the people who are logged in, and myself up here, will see a running sort of flow of questions that we will address later during a group question and answer session at the end of the presentations. You all will have the opportunity to like questions as they come through, so that you don't have to, if there's a question that you really want to know the answer to that someone else has asked, you can let us know that, and I'll see what the audience feedback on different questions is so that I can prioritize those during the discussion session. And also, if you're watching the slides on your device rather than on the screens, and you notice that there's any lag, hit the resynchronization icon, and that will reset it and bring you back up to the current slide. So I thought maybe we would do a practice question so you could sort of see what would happen when we ask questions during the talk. And so we're going to make this just a really simple one, and it will help me understand who our audience is today. Who are you? Answer A is a hematologist. Answer B is a physician in another specialty. C is a trainee, either a fellow or a resident. D is a nurse or mid-level provider. And E is somebody who wandered into the wrong room. And to clarify, this morning's session is about amyloidosis. So if you could take a moment to, I don't know if everyone is logged in, but anyone who already is, if you could take a moment to answer the question, we'll get to see sort of what happens. Right? So the graphic that we'll see as answers come in is we see this sort of pie chart, and we sort of see the back and forth, the push and pull with different answers, and it will finally ultimately settle out with what the most common answer is, I think expected in this room. Hematologists are going to predominate at ASH, but we also made sure that this event was publicized to cardiologists, nephrologists, gastroenterologists, and other specialists. Okay, so the next slide. This is for CME credit, which is provided by Wayne State University. It's good for 3.25 hours of AMA PRA Credit 1 credits. That's for attendees of the live event, not for people watching on the web stream. You need to make sure that you're registered with Wayne State University, and there's a registration form at the desk when you check in. We need you to fill out an evaluation form in order to claim your CME credit, and the certificate for that credit can be printed at the end of this session, or if you want, emailed to you later. Finally, I want to congratulate a few people. This is our third Untangling Amyloidosis Symposium, and with each one, we've had trainee travel grants supported generously by the Amyloidosis Foundation. And this program is the Don Brockman Trainee Travel Grant Program. And this year there were 5 awardees. And in order to be considered for this grant, the awardees had to propose an article to discuss in an online journal club called Amyloidosis JC that we do on Twitter. And they had to propose an article, and they had to co-moderate the session to do it. And I think I saw most of the awardees here, and I'm going to just recognize everybody. Dr. Vijendra Singh, if he's here, if you could stand up and just stand up and stay up until I've announced everybody. Dr. Suresh Balasubramanian, Dr. Holly Lee, Dr. Alfred Chung, and Dr. Oliver Cohen, all here, all led great discussions on topics ranging from MRD in AL amyloidosis to upfront treatment with bortezomib-based therapy, the role and outcomes of renal transplant in AL amyloidosis, and I'm forgetting, and the cardiac effects of patisiran in patients who are treated for ATTR amyloidosis. So congratulations to the 5 of you. You all did great. The discussions took place over a 1-month period on Twitter, and if it sounds nerdy, I said last year, if it sounds nerdy, it really was. You can't even imagine. But we had 50 participants in these 4 sessions, and these are the latest of 17 sessions of Amyloidosis JC that we've had over the years, and monthly sessions will be resuming in January of 2020, so be on the lookout for that. The Trainee Travel Grant Selection Committee is shown here. Andrew Kinn from Karmanos chaired this committee and did a great job, and he's here. Sasha Tuckman from University of North Carolina, Naresh Bhuma from Ohio State, and Edward Libby from University of Washington not only reviewed all the applications and selected the awardees, but they also co-moderated sessions of the Twitter Journal Club, and I appreciate all the work that you put in regarding this program. So thank you guys. And finally, if anyone here feels the inclination to tweet about the content of this is the hashtag we're going to be using, UA2019FSS, Untangling Amyloidosis 2019 Friday Satellite Symposium. So if you tweet, please use this so that we can sort of keep track about what's happening online. We're going to move into our first speaker, one of my favorite colleagues, Vaishali Sanchrawala from Boston University is going to be giving the Norman R. Schurmaster keynote lecture, which is sponsored by Amyloidosis Support Group, Inc. And she's going to be talking about high-dose chemotherapy and autologous stem cell transplant in AL amyloidosis. Thanks.
Thank you. So good morning, everyone. Welcome to this Untangling Amyloidosis session. My topic today is going to be high-dose chemotherapy and autologous stem cell transplantation in AL amyloidosis, its role in the era of emerging new therapies. These are my disclosures. I will start by a case presentation of a 48-year-old woman with AL amyloidosis diagnosed by renal biopsy when presented with leg swelling and protein in the urine. Her renal parameters included low serum albumin, normal serum creatinine, 24-hour urine protein excretion of 7 grams per day, and estimated GFR of 75 ml per minute per meter square. This placed her into renal stage 2 disease with eGFR of greater than 50 and 24-hour urine protein excretion of greater than 5 grams per day. Her cardiac parameters included elevated NT-proBNP, elevated BNP, normal troponin I, normal left ventricular ejection fraction, and a New York Heart Association Class 1. This placed her into Mayo Stage 2 disease and Boston University Stage 2 disease as well, with elevated NT-proBNP, BNP, and normal troponin I. Markers of plasma cell dyscrasia were elevated free lambda light chain levels, normal serum free kappa light chain levels, and an abnormally low ratio. Bone marrow biopsy showed 5% lambda-typic clonal plasma cells with normal cytogenetics and FISH analysis. Immunofixation electrophoresis of urine showed free lambda light chain monoclonal protein. What is the best option for treatment for this 48-year-old lady? And the options are oral melphalan dexamethasone, high-dose melphalan and stem cell transplantation, cyclophosphamide bortezomib dexamethasone, Cybor-D, bortezomib and dexamethasone, or RVD, lenalidomide bortezomib dexamethasone. Please vote on your phones, on your... I think we are done. And I'm glad that this is what came up. So Cybor-D is the winner. Majority, 54% of the audience voted for cyclophosphamide, bortezomib, and dexamethasone as the treatment of choice for this 48-year-old lady with AL amyloidosis with renal stage 2 and cardiac biomarker stage 2 disease. In the next 20 minutes, I'm going to try to convince you that high-dose melphalan and stem cell transplant probably is a better choice for this woman and is better choice for some selected patients with AL amyloidosis. So this would have been my answer. Again, my bias is, or my disclosure here is that I'm a transplant physician. So high-dose melphalan and stem cell transplantation was developed for the treatment of AL amyloidosis in the early 1990s. The development of this treatment approach was prompted by promising results of similar regimens in the treatment of multiple myeloma. Objectives of the initial clinical trials were to determine tolerability of this treatment approach in patients with multi-system organ involvement, to determine efficacy of this treatment in inducing complete hematologic response, and finally, to determine whether complete hematologic response leads to reversal of amyloid-related disease and improved survival. Prior to 1990s, conventional treatment consisted of oral melphalan and prednisone, and 2 randomized pivotal clinical trials, one performed at the Boston University and other one performed at the Mayo Clinic, showed that the oral melphalan prednisone improved survival of patients with AL amyloidosis to 12 to 18 months. However, hematologic complete responses, long-term survivals, and organ responses were rare with this form of treatment. Long-term outcome of first 80 patients following stem cell transplantation was published by our group in the early 2000s, showing that the median overall survival was greater than 10 years for those who achieve a complete hematologic response compared to 4.1 years for those who did not achieve a complete hematologic response following stem cell transplant. Newer anti-plasma cell therapies are questioning the role of stem cell transplantation in AL amyloidosis. Novel agents have been incorporated into different phases of stem cell transplantation for AL amyloidosis, either as induction therapy or as conditioning regimen along with high-dose melphalan, or after stem cell transplantation as adjuvant therapy or consolidation therapy. A phase 2 prospective clinical trial of 35 patients with new diagnosis of AL amyloidosis received 2 cycles of induction therapy with bortezomib dexamethasone, followed by bortezomib high-dose melphalan conditioning and stem cell transplantation at Boston University Amyloidosis Center. In this trial, there were high rates of hematologic responses with 63% complete hematologic response and 37% very good partial hematologic response. Moreover, there was no negative impact of bortezomib induction on stem cell collection. However, 5 of 35 patients, that's 14%, who were eligible for stem cell transplant at the time of enrollment did not proceed to stem cell transplant due to clinical deterioration during induction therapy. Long-term follow-up analysis of this trial was recently published with a median follow-up of 77 months, showing median overall survival and progression-free survival have not been reached. Furthermore, hematologic relapse occurred in a low percentage of patients at 15% at a median of 42 months, and organ progression occurred in 4% at a median of 37 months. Deep organ responses were also evident on this trial, with renal and cardiac responses occurring in 65% and 88% respectively at 5 years post-stem cell transplantation. A randomized prospective controlled trial of induction therapy with bortezomib and dexamethasone followed by stem cell transplantation versus stem cell transplantation alone in the treatment of AL amyloidosis with renal involvement was published by the Chinese group, again favoring induction therapy prior to stem cell transplantation with respect to hematologic complete response at 1 year and overall survival at 2 years. Recent publication from the HOVON 104 clinical trial, which was a phase 2 trial of 50 patients with new diagnosis of AL amyloidosis, received 4 cycles of bortezomib dexamethasone induction followed by stem cell transplantation, showing a hematologic response rate after stem cell transplant of 46% complete hematologic response and 26% very good partial response. On an intention to treat analysis, hematologic complete response was 32%. The conclusion of this trial was this was a futile trial because of pre-planned statistical design which did not meet the hematologic complete response guidelines. In this trial as well, 15 of 50 patients, that's 30%, did not proceed to stem cell transplant due to complications during induction therapy. So, induction therapy should be used with extra caution prior to stem cell transplantation in patients with AL amyloidosis, as complications during induction treatment can make patients ineligible for stem cell transplant, which would be the most definitive treatment. Bone marrow plasmacytosis can affect survival in AL amyloidosis. Bone marrow plasmacytosis of greater than 10% can have poorer prognosis. In a multivariate analysis, bone marrow plasmacytosis of greater than 20% had an independent predictor of overall survival following treatment in AL amyloidosis. We at Boston University looked at role of induction therapy prior to stem cell transplantation based on plasmacytosis in over 550 patients. In this study, bone marrow plasmacytosis was not an independent predictor of overall survival as shown on the left Kaplan-Meier survival curve. Furthermore, role of induction therapy for patients with bone marrow plasmacytosis of greater than 10% also did not have improvement in overall survival. Novel agents have been incorporated after stem cell transplant as either adjuvant therapy or consolidation therapy, with showing deepening of hematologic response following stem cell transplant. And this effort has been led by the group at Memorial Sloan Kettering. Maintenance therapy, on the other hand, has not been studied in clinical trials and is not recommended routinely as standard of care following stem cell transplantation. Of note, ixazomib is currently being studied as a maintenance therapy after stem cell transplantation, and this clinical trial is currently accruing, and the principal investigator is Dr. Heather Landau at Memorial Sloan Kettering Institute. We at Boston University Amyloidosis Center looked at the long-term results of stem cell transplantation over last 20 years in 629 patients with AL amyloidosis. Objectives of this analysis were to address durability of hematologic response following stem cell transplantation and to address long-term survival following stem cell transplantation in AL amyloidosis. Key eligibility criteria were tissue diagnosis of amyloidosis, evidence of a plasma cell dyscrasia, and at least one vital organ involvement, along with minimum measures of performance status, cardiac function, pulmonary function, and hemodynamic stability. Patients were treated on several sequential IRB-approved clinical trials, and age, renal function, time from diagnosis, prior treatment, and conditioning regimen varied among clinical trials. Key exclusion criteria were persistent pleural effusions refractory to medical management, exercise limitation with less than 2 to 3 flights climbed during pulmonary function tests, and or oxygen uptake of less than 15 ml per kilogram per minute on cardiopulmonary exercise study, direct hyperbilirubinemia of greater than 2 milligrams per deciliter, and significantly elevated cardiac biomarkers. 629 patients with AL amyloidosis underwent high-dose melphalan and stem cell transplant from 1994 to 2014. The median age was 57 years, and half of the patients had cardiac involvement or greater than 2 organ system involvement. Majority of the patients received full high-dose melphalan at 200 milligrams per meter square, and 44% of the patients received modified high-dose melphalan at 100 to 140 milligrams per meter square. Treatment-related mortality, defined as deaths within 100 days after stem cell transplant, occurred in 7% of the patients. Majority of these patients had significant cardiac involvement. Fortunately, treatment-related mortality in the last 15 years is less than 5% due to better patient selection, as well as availability of other non-stem cell transplant regimens. In addition, there were 11 deaths during stem cell mobilization and collection, and 5 deaths during stem cell infusion, again denoting the medical complexity and frailty of this patient population during this aggressive form of treatment. Hematologic complete response was achieved by 40% of the patients at 6 to 12 months following stem cell transplantation. On an intention to treat analysis, hematologic complete response was achieved by 35% of the patients. 45% of the patients who received full high-dose melphalan at 200 milligrams per meter square achieved a hematologic CR, compared to 34% of the patients who received modified high-dose melphalan. Median overall survival for 629 patients following stem cell transplantation was 7.6 years, and 30% of the patients achieved a long-term survival of greater than 20 years. Hematologic relapse, defined as recurrence of plasma cell dyscrasia after achievement of a complete hematologic response, occurred in 32% of the patients at a median of 4.3 years, ranging from 1.5 to 21.5 years. Biochemical relapse, defined as recurrence of monoclonal gammopathy without organ progression or without elevation of involved serum free light chain analysis, occurred in 16% of the patients, and these patients did not require additional therapy at a median of 6.5 years. Organ responses were also evident following stem cell transplantation. nephrotic syndrome improved in 70% of the patients following hematologic complete response after stem cell transplantation, compared to 30% improvement in proteinuria for those who did not achieve a complete hematologic response. Quality of life, as measured by short form 36, also improved following stem cell transplantation. All SF-36 scores, including mental component summary and physical component summary, reached the age-matched US population norms as shown in the black circles on the graph, reached at 2 years following stem cell transplantation. Hepatic response, defined as greater than 30% reduction in enlarged liver or a 50% decrease of an elevated alkaline phosphatase, occurred in about 60% of the patients at 1 and 2 years following stem cell transplantation. Cardiac responses were also evident following stem cell transplantation. Echocardiographic variables and biomarkers improved following stem cell transplantation. Global longitudinal strain with apical basal ratio as well as cardiac biomarker of BNP improved significantly for those who achieved a complete hematologic response following stem cell transplantation. A large series of experience of stem cell transplantation in AL amyloidosis comes from the registry of CIBMTR, where 1,500 patients were enrolled on this or were analyzed on this study. 5-year overall survival has improved dramatically from 55% to 77% following stem cell transplantation in the last 20 years. Estimated 15-year overall survival of 33% was also reported in a large series from Mayo Clinic investigators. UK National Amyloidosis Center reported on their outcome of 264 patients who underwent stem cell transplantation with a median overall survival of 8.2 years and 33% of the patients achieving a long-term survival at 20 years. Unfortunately, there are no direct comparison of non-stem cell transplant regimens to high-dose melphalan stem cell transplant with respect to hematologic response, overall survival and progression-free survival, organ response, and quality of life measures, except for the French randomized clinical multicenter clinical trial where 100 patients with AL amyloidosis were randomized to receive oral melphalan dexamethasone versus high-dose melphalan stem cell transplant, showing overall survival superiority with oral melphalan dexamethasone. This trial has been criticized for increased treatment-related mortality of about 26% in the stem cell transplant arm. Single-center experience of stem cell transplant and non-stem cell transplant regimens with respect to overall survival was reported by the Mayo Clinic investigators in the last 20 years. We would focus on the time period of 2010 to 2014, and the 2-year overall survival was 94% for the patients who received stem cell transplant and 47% for the patients who received non-stem cell transplant regimens. Similarly, progression-free survival for the time period of 2010 to 2014, 2-year progression-free survival was 73% for those who received stem cell transplantation and was 30% for those who received non-stem cell transplant regimen. Hematologic and organ responses from large publications of stem cell transplantation versus standard therapies with non-stem cell transplant regimens are shown here side by side. Hematologic complete response, renal response, and cardiac responses were deeper and profound following stem cell transplantation, not randomized clinical trials, although. Renal stage, as defined by eGFR as well as 24-hour urine protein excretion, can predict 2-year risk of dialysis and annual risk thereafter. For the patient that I described had renal stage 2 disease, and the 2-year risk of dialysis is 11 to 25%, as reported by the European investigators, where majority of the patients had received non-stem cell transplant regimen. Her risk at stage 2 disease, at 2-year risk of dialysis, would be 3% when patients were treated in our center with uniform treatment of stem cell transplantation. Renal response, defined as greater than 30% reduction in proteinuria, can also predict 2- and 5-year risk of dialysis following treatment. As reported by the European investigators, if a patient achieves renal response following treatment, 2-year risk of dialysis is 3 to 10%. Again, majority of the patients in this study were treated with non-stem cell transplant regimens. As reported by our group, renal response following stem cell transplant has a 2-year risk of dialysis of 0%. Longitudinal analysis of quality of life based on short form 36 and AL amyloidosis was performed at my institution in about 200 patients. 41 and 47% of patients achieved clinically meaningful improvement in physical and mental component summaries of SF36 following stem cell transplant regimen. This is in contrast to 23 and 29% of patients achieving clinically meaningful improvement in physical and mental component summary of SF36 following non-stem cell transplant regimens. In conclusion, long-term outcome and results of high-dose melphalan and stem cell transplant in selected patients are unprecedented, with 30% of the patients alive for 20+ years. Moreover, high-dose melphalan and stem cell transplant can lead to durable hematologic complete response with low rate of hematologic relapse, and novel therapies can lead to high hematologic responses. However, durability of these responses is not known off therapy, and follow-up times are quite short. I would like to thank all the members of the basic science and the multidisciplinary clinical team at Boston University Amyloidosis Center who work on the scenes and behind the scenes to make this disease into more manageable and chronic disease. And thank you for your attention. I also would like to inform you guys about this masterclass that is happening on January 10th with all the hands-on workshops with how to do abdominal fat pad aspiration, how to read technetium pyrophosphate scan, how to get prior authorization for some of these newer agents for transthyretin amyloidosis. Thank you for your attention. And now I would like to invite Dr. Stefan Schonland, who is going to be presenting on should cytogenetics or FISH testing be used to select initial therapy for AL amyloidosis. Stefan is a consultant at the Amyloidosis Center at Heidelberg University Hospital in Heidelberg, Germany.
Next one, I have to introduce you. So good morning. This topic actually was chosen not by me, by some other, because I think it's a rather difficult question, and I will show you in the next 20 minutes why. So these are my disclosures, and I also will talk a little bit about venetoclax. And I also will start with a case report. So we have a 44-year-old male with AL lambda, with a small plasma cell clone, immunofixation serum negative, in urine lambda positive, with a ratio FLC of 0.3 and a difference just of 40 milligram per liter. And as expected in the bone marrow, less than 5% of plasma cells with lambda in flow and histology. And with iFISH, we found translocation 1114 in 80% of the cells. The amyloid organ involvement was renal with stage 1 and cardiac with stage 2. And it was in rather good shape, so there was only a few symptoms, the Karnofsky index of 90%, and the past medical history was unremarkable. So this is one of the proposed models of primary events and clonal evolution for multiple myeloma. Of course, an entity which is much better studied as AL amyloidosis. And here you see that and we are focusing on that. So on those primary events, in opposite to the secondary events, we have probably 2 or 3 groups as primary events, and this is hyperdiploidy and the non-hyperdiploid, which are mainly focused then on the translocations. And here you see the schedule of disease progression coming from ENGAS to smoldering myeloma, multiple myeloma, which requires treatment, and of course relapsed myeloma. So this is the model for myeloma. So actually, I think we should start to ask the question, should these cytogenetics testing be used for selecting initial therapy in multiple myeloma patients? And if you think about that, we also see it's not really easy. And I can just tell you what is in Germany is our politics about this, and I think this is always a big debate about it. So actually in Germany we just say for high-risk patients defined by translocation 414 or deletion 17, we offer those patients a tandem high-dose treatment with autologous stem cell support. And we also offer the patients with deletion 17 a maintenance after this transplant. So it's not very sophisticated, I would say, for myeloma. But then coming back to AL amyloidosis. So we and other groups in the last 10, 15 years really studied hard the influence of IFISH cytogenetics on the biology and also on the disease and the prognosis. And just a couple of years ago, we really asked the questions, is our panel, our FISH panel, big enough and good enough to really cover all gains and losses we see in those patients? And so we studied together with our colleagues from the Genetics in Heidelberg a genome-wide copy number array and compared these results with IFISH. And here just you see an overview about the gains and losses. And what was really expected was the gain of 1q1, and all the uneven chromosomes, and of course the lesion of 13, 15, and 17. And now we really correlated this with our probe, IFISH probe, and the concordance was actually close to 100%, so between 90 and 100%. So I really think with the IFISH we cover most of the genetic aberrations in this disease. So it's really a reliable technique to characterize AL genetics. So coming to the clinical and basic data about IFISH cytogenetics in AL. First, I show our own data. So we can see that high sensitivity, we enrich the bone marrow, 40 ml bone marrow with CD138, and we get a high sensitivity for IFISH. So more than 90% of the patients really, we see an aberration. And this is translocation 1114 in half of the patients, or even more now. And this is associated with light chain only type, so the Benz-Jones type, another hallmark feature of AL. And in opposite to myeloma, we only see less than 10% the so-called high-risk cytogenetics. But we see in nearly 20% of the patients a gain of 1q21. And this is again associated with a higher plasma cell infiltration of the bone marrow and lambda light chain restriction. And finally, hyperdiploidy, also in opposite to myeloma, we only find in 10 to 15%. And this is now associated with kappa, with a higher plasma cell infiltration and a higher age at diagnosis and a heavy chain type. So actually, I would say that this is a more myeloma-like feature here. Our colleagues from the Mayo Clinic also did these kind of studies, and they also, with their assay, had a 90% sensitivity to really see some aberrations in these patients. And they also found that translocation 1114 is the hallmark and the most, the one with 40% seen in those patients. The trisomy, with a little kind of other definition that we used, was that they could show in 25%. And again, those patients were older at diagnosis, had also a kappa isotype and more DFLC and a higher plasma cell infiltration of the bone marrow at diagnosis. And as we did, they also looked how much was the overlap between translocation 1114 and the trisomies, and this only occurred in 4%, like we have shown as well. So I think pretty good validation of the previous data I have shown. So confirmation for the frequency of translocation 1114 and also the association of trisomies with age, kappa, and the clonal size. Next, we try to get a hint about clonal evolution using an oncogenic tree model, which is focused on the frequency of an aberration and a combination of aberrations in individual patients. And here you see the analysis of close to 700 patients with AL. So here is the root, and this is the likelihood for the branch coming next. And you actually here see, as we hoped for, two groups. So this is again the translocation 1114 group and the hyperdiploidy group. And when we did this for myeloma samples as well, we kind of saw the same thing, a branch for 1114, a branch for the hyperdiploidy. And then here's some high-risk features. Next, we wanted to know the intraclonal heterogeneity in these patients, if there's a difference between myeloma and AL amyloid. And here we looked for subclones in these patients, and a subclone was defined as a clone size below 2/3 of the largest clone we found in a patient, and an absolute difference of 30% to really be sure that we are dealing with subclones. And also what we did here in this analysis, we divided the AL patients group and the myeloma or the PC non-AL group in MGUS, smoldering myeloma, and multiple myeloma with standard definitions, because we know that we will see much more MGUS and smoldering myeloma-like patients in AL than we do in myeloma. So to cover this point as well. But still, you see, in each of this category, we have less subclones in AL than in myeloma. So has this something to do with AL and with the light chain protein, or has this something to do just with the biology of the plasma cell? We wanted to find out in that paper. So first we said subclones are less frequent in AL, regardless of the stage of the plasma cell dyscrasia. Then we checked each individual or some individual genetic aberrations, and here you see the figure for translocation 1114. And actually, those patients, they have always a main clone with this translocation. So it's very frequent as main clone. And this is true for AL amyloid, and this is true for the myeloma. So the opposite we found, or a slight opposite, for gain of 1q21 and deletion 17p13. There you see in red and green that we have also patients with subclones. All over. And if you look for deletion 17, you even see that this is increasing if the stage of the plasma cell disorder is also increasing. So then we really wanted to know what are the main factors driving this development of subclones. And here you see a multivariable analysis taking into account of the disease, the underlying disease, high-risk clones, hyperdiploid clones, 1114, kappa versus lambda, and also if there's a heavy chain or not. And at the end, if it matters if the patient has amyloid or just myeloma. And at the end, you see that only translocation 1114, or this is the main driver which telling us if these patients got a subclone or not, regardless if they have myeloma or AL. So the conclusion here is the presence or absence of subclones are related to the cytogenetic aberration rather than the type of plasma cell dyscrasia. So, but now coming to the prognostic features, because that's what actually the title of the talk. So first, we analyzed the influence of translocation 1114 in patients treated first line with bortezomib. And first, we could show that there was an inferior remission rate in those patients with 1114 when they were treated with bortezomib, and this was a significant difference. And also, if we checked event-free survival and overall survival here, there was a difference. And we could also validate this in a small group treated with Cybor-D regarding event-free survival. And then next, we also made a multivariable analysis. And again, translocation 1114 was a negative factor regarding overall survival and hematological event-free survival. So for that, we can say translocation 1114, it is an unfavorable independent prognostic factor in AL treated with bortezomib. coming to the case report. We gave 2 cycles of Cybor-D. The side effects were transient gain of weight. Hematological response was good, was a low DFLC PR with less than 10 milligram per liter, and no organ response after 2 months. So we decided to give another 2 cycles, and the side effects were kind of the same, with in addition the nerve damage, and we got a hematological progression, so a rise of DFLC to 50, 59, and no organ progression, so it was kind of stable. So the question for the audience now would be, what should be the treatment strategy after cycle 4? Should it be starting second-line treatment with lenalidomide, continuing treatment with Cybor-D, considering ASCT, or stopping therapy? Oh. Oh, it's rather clear, I would say. So considering ASCT, and what did I put? No, it's not working. Oh, okay, this was also my answer, saying hello to Vaishali. Okay, so what are the data for translocation 1114 and high-dose chemotherapy? Again, we did the same kind of analysis, focusing on patients with transplant. First checked the CR rate in response to this treatment, and we saw that patients with 1114 had a higher percentage of CR after transplant, 40 to 20%. Next, we checked event-free survival and overall survival, and for event-free survival, there was this difference with 0.05, and in overall survival, there was this difference of 0.07. Checking again the multivariate analysis for event-free survival, we could see a very good hazard ratio of 0.5 as a prognostic favorable factor, translocation 1114, but for overall survival was the same hazard, but we missed the significance here, even after a follow-up of 17 months actually. So, but still, we would conclude T1114 is a favorable independent prognostic factor in AL patients treated with ASCT. And again, coming back to the Mayo Clinic results regarding overall survival, they also could show that patients treated with bortezomib and 1114 positive have a worse prognosis, and if they treat those patients with high-dose chemotherapy, there is no difference regarding overall survival. They also did a multivariate analysis regarding the well-treated patients, and here again you find 1114 as a negative factor. So you also conclude this is a confirmation of previous data regarding translocation 1114 and bortezomib. Yeah, there's only few data around about high-risk cytogenetics. So here are a few Heidelberg data about deletion 17, translocation 1416, and translocation 414, just 13 patients. But if you see those patients when they are treated with bortezomib, there is a slight difference for event-free survival, and there was a big difference for overall survival. So we might conclude here that high-risk cytogenetics are not an unfavorable prognostic factor in AL patients treated with bortezomib. And due to the activity of Ray Comenso, we also did a multi-center analysis worldwide, just focusing on patients with AL amyloidosis and deletion 17. And as you see here in the retrospective study, the treatment was mostly based on Velcade, but there was also some high-dose patients. And 50% of the patients were rather sick, we have to say, but the response achieved with these kind of treatments was not bad, and the median follow-up was 30 months here. And these are the results, the Kaplan-Meier plots for overall survival with a median of 50 regarding overall survival. And the only prognostic feature we could find out here in those 44 patients was that a more complex karyotype combination or if deletion 17 occurred in more than 50% of the cells, this was associated with a slightly worse prognosis. So, coming to the next case report again. So there was a decision for ASCT. We mobilized the stem cells with cyclophosphamide and collected 2 transplants, and did the transplant with a complication of fever and mucositis. And there was a good hematologic response, a CR with a ratio of 1, an organ response after 6 months with an NT-proBNP of 470 nanogram per liter, and an organ response for renal after 12 months with a decrease in proteinuria. So the question for the audience, the next question is, what should be the treatment strategy in patients with AL amyloidosis and translocation 1114? ASCT upfront. Treatment should be risk adapted, or CyBorD and transplant, or a tandem ASCT followed by maintenance with bortezomib. Oh. It's difficult, huh? So 4 is maybe not the winner, but 1 and 3. Okay. So my answer was treatment should be risk adapted. And why? Because this is kind of now the scheme we have if we want to treat patients with low risk or intermediate and high risk. And for the myeloma physicians, I always introduce these 3 comments here. So I say the low risk patients, they are treated almost like patients with myeloma. The intermediate risk, they are not treated as myeloma, and the high risk, actually, we don't know. And this risk assessment is mostly based on cardiac function. So, but where do we find here now results of IFISH cytogenetics? So we find them here in regarding the intermediate risk and BMDEX and CyBorD and actually MDEX as well. And it's not in that figure, so we modified it. We could also put it in here. So that would be my my overview about risk-adapted treatment in AL, and also including some features, some genetic features. So finally, coming to the future perspectives in patients with AL amyloidosis and also patients with 1114 translocation, we have a new drug there. It's venetoclax. It's an oral small molecule BCL2 inhibitor approved by the FDA for both CLL and AML, and it's currently studied in relapsed refractory myeloma patients harboring 1114 translocation, and there are already a few case reports of AL patients harboring this translocation. And just included here in this slide the first one, where venetoclax included a complete remission in a patient, which already was treated with CyBorD, which you see here. And if you just focus on the DFLC, where it's going down, and then venetoclax, actually, it was switched to venetoclax, bortezomib dexa, stopped due to side effects, a little increase, and then this patient got venetoclax again, and DFLC was going into normal after 1 year. So this is the future perspective, but now coming to the summary in IFISH and AL amyloidosis. IFISH is a reliable technique to characterize the genetics of the plasma cell clone. I hope I convinced you about that. It tells us something about the biology. Translocation 1114 is the hallmark of the disease, and it's associated with bench-shown phenotype and lacks complex clonal landscape. Hyperdiploidy shows more multiple myeloma features, and the high-risk features are less common in AL. Regarding treatment, in translocation 1114, positive patients, bortezomib is less effective, but the transplant at least overcomes its negative impact. So, but the question was, should cytogenetics testing be used to select initial therapy of AL? And I would say no, because risk-adapted therapy is most important to consider. Response in these patients can assess and should be assessed very early to see if the treatment delivered is really effective. And also other organ involvements should be considered, like the nerve damage, for example. But we could say, there is a but, it might be used for the consideration of ASCT, the timing of response assessment, earlier or later, maybe, and bortezomib in high-risk cytogenetic patients, and of course in the design of new combination therapies like the triple MDEX plus bortezomib, or including venetoclax. So these are my acknowledgements. I want to thank the whole clinic team in AL in Heidelberg, the genetic team there, and also the statistical team mentioned here. But of course, I also want to say thanks to all these international collaborators. I want to thank the genetic team in the Mayo Clinic, and I want to thank the ISA board, which is working hard together with the Spanish people to organize the next meeting there in Tarragona. And last but not least, also talking about international collaboration, I want to thank Marco Bassett, who joined us for 1 year as a guest physician from Pavia, coming in Heidelberg for this year, and he helped me a lot while doing this, working on this presentation. And also I want to thank the funding sources and the patients and their families. All patients analyzed here donated 40 to 80 ml bone marrow, and so I also have a big thank to the patients here. And now I say thank you for your attention. So, and the next speaker is Jeff Sonder. He's talking about standard and emerging anti-plasma cell therapies for relapsed AL amyloidosis.
Thank you. Well, both of those talks are going to be a hard act to follow. Great discussions about upfront treatment, but I think regardless of what we choose for transplant and non-transplant patients, many of them relapse, and so we need to know something about the therapy for patients beyond first-line therapy, and that's my topic for today's talk. These are my disclosures, and I'm going to also start with a case. A 63-year-old woman with lambda light chain AL amyloidosis and a past medical history of hypertension and hypothyroidism presents with Mayo cardiac stage 3 disease and Pavia Heidelberg renal stage 2 disease, and the renal disease was on the basis of proteinuria. Initial therapy for this patient was Cybord-D for 6 cycles, and the patient achieved a complete hematologic response. There was an improvement in cardiac biomarkers, but no renal response. So the patient had persisting proteinuria. And 3 years later, which is a long time for Cybord-D, as we heard, the lambda light chains began to rise and proteinuria began worsening. Daratumumab was started as second-line therapy, but after the first 8 weeks of therapy, the patient had achieved less than a partial hematologic response. What should we do now? So here are our choices. We can continue daratumumab to see if the response does actually improve over time, switch to IMiD-based therapy, initiate other chemotherapy, evaluate eligibility for high-dose chemotherapy and stem cell transplant now as second-line therapy, or consider a clinical trial. Please vote. Okay. D seems to be the runaway favorite, which surprises me, and we'll talk about the data for all of these options as we go forward. I actually had as my answer any of them, although I thought that A was probably the weakest choice. because the chances of a response continuing to improve after the first 8 weeks is probably in the neighborhood of 15 to 25%. And so there are other options which would have a higher chance of inducing a response, and any of these other things I thought could be considered, and we'll go through them. Before we do that, though, let's talk about the considerations that we make when we're thinking about second-line therapy or just therapy for relapsed amyloidosis in general. First, obviously, we're assessing whether resumption of therapy is actually indicated based on rising light chains or deteriorating organ function. We think about how the amyloidosis responded to an original therapy, and also, did the patient progress on last therapy, or did the patient progress sometime after that therapy, suggesting that they may not be completely refractory to that agent? How did the patient tolerate initial therapy? Were there side effects or problems with a specific regimen? And is the patient's health status now, as we consider therapy for relapse disease, different than their health status was originally? Could be worse due to progressing symptoms or persisting side effects. Could be better because of the response that we saw with initial therapy. And did the candidacy for any of the therapy options that we listed actually change now compared to when they were first diagnosed? And then are there any coexisting medical problems which might affect the choice, specifically by making certain side effects more problematic or more likely? The question I always ask, of course, is there a clinical trial available? And I would emphasize to everybody that they should be thinking about that if we want to move the field forward. So in terms of the timing of initiating therapy, this is highly variable. Even at the Mayo Clinic, an internationally renowned center of excellence, when they looked at their own internal data about the reason for initiating second-line therapy after relapse from first line, the reason varied. In some cases, about a third of patients, it was a rise in the light chains. In another third of patients, it was a rise in the light chains with deteriorating organ function. In another subset of patients, it was just deteriorating organ function. And in some patients, it was actually much less defined than that. And this is at one of the best amyloidosis centers in the world, which I think underscores how confusing it can be for physicians who see far less numbers of patients. I think there are some situations where it's actually an easy call. When a patient has a rising involved free light chain and a widening difference between the free light chains with deteriorating organ function, that's a no-brainer. Therapy should absolutely be reinitiated at that time point. It's a little bit harder with an asymptomatic rise in the light chains, but I think most people are moving towards reinitiating therapy as light chains start to rise, particularly if they're rising quickly. And then the hardest call, I think, is organ deterioration without a rise in the free light chain, the involved free light chain. It's important to remember that there are some patients who may have deteriorating organ function not as a result of continued amyloid deposition, but as a result of disease processes set in motion. The one I think that we commonly face is the patient with persisting proteinuria and renal injury from the proteinuria rather than ongoing light chain deposition. But that said, in my own practice, I'm most inclined to treat these patients if the residual stable light chain is actually still elevated and not in the normal range. That, to me, is a subset that I'm inclined to treat with declining organ function. So let's start going over this case and the choices for this question. First, the daratumumab, before we asked the question, that was a good choice. The data on daratumumab in relapsed amyloidosis is actually outstanding. There have been several retrospective case series now published. One of the earliest ones was from Dr. Kaufman and colleagues at Stanford. This was 25 patients who had had a median of 3 prior lines of therapy, and the overall response rate was 76%, with more than half of patients achieving a very good partial response, which means a marked decrease in the involved free light chain and a difference between the involved and uninvolved free light chain of 4 milligrams per deciliter or less. At this meeting, there's an interesting abstract by Dr. Milani, who's sitting right over there. 72 patients with amyloidosis in Italy who have more than 10% plasma cells in their bone marrow, making daratumumab available to them. These were all relapsed patients, and 65% of the patients got daratumumab alone, and the other third of the patients got daratumumab combinations like we use in multiple myeloma, pretty much a split between DVD and DRD. And in this patient group, they had also had a median of 2 prior lines of therapy. And interestingly, the response rates, whether they got monotherapy or combination therapy, was above 80%. And there was actually no statistical difference for the combinations compared to the monotherapy group, although the numbers were a bit small to really prove whether there was any significance or not. There have been case reports of daratumumab combinations published. This is an example of one, a patient who had a light chain plateau with clinical worsening after 5 cycles of Cyborg-D, and they were switched to daratumumab, pomalidomide, and dexamethasone, had an excellent hematologic response, and ultimately was able to go on to autologous stem cell transplant. And I think we're going to be seeing more and more use or interest in daratumumab-containing combinations, but based on some emerging data in a randomized study that we've already heard some details about from Dr. Comenzo at past meetings, daratumumab may very well be used up front soon. This is a study comparing Cyborg-D with or without subcutaneous daratumumab, followed by daratumumab maintenance. That's a 370 patient randomized trial, but we did have a safety run-in for this combination where all the patients got treated with the study arm, and the response rates of 92% with 3/4 of the patients achieving a VGPR are in excess of what we expect for Cyborg-D, even though this is basically the equivalent of a phase 2, and we shouldn't get overly excited. This has definitely prompted enthusiasm for the idea of adding daratumumab to chemotherapy and amyloidosis, as it has in multiple myeloma. And if this actually comes to fruition and patients are getting daratumumab up front, we're going to need to do a lot of work to find out about how to use it later, or even if we can use it later in other combinations. Final thoughts on anti-CD38 therapy. As I mentioned, sub-Q DARA is going to become available. That will be very helpful for our patients, both in terms of the infusion time, but also the fluid load for amyloidosis patients. Isatuximab with dexamethasone is being studied in a Southwest Oncology Group trial right now, and there's also an ongoing trial at MD Anderson of daratumumab, ixazomib, and dexamethasone in relapsed patients. So choice B in our question was IMiD-based therapy. There's been tons and tons of phase 1-2 level data using IMiDs. The initial work was with lenalidomide starting back in 2007, and in the earliest studies at Boston and Mayo, the thing we really found out is that lenalidomide can't easily be used at a full myeloma dose in amyloidosis patients, and the starting dose for patients, particularly frail patients, probably ought to be 10 or 15 milligrams, and it's unusual to treat patients with higher doses of lenalidomide. This actually led to a number of patients coming off study from the Mayo phase 2, and that's probably what explains the lower overall response rate in that particular study. I think what we see in the other studies here is that the response rate is in the 50 to 65% range with lenalidomide, and in the more recent British and Greek series, we see that the response rates in patients who previously had bortezomib, so relevant to our patient, we expect response rates also between 50 and 60%. So definitely a potentially useful agent in this group. There's also data on lenalidomide, Cytoxan, and dexamethasone that's been published by several centers. I'm not going to show you that data. That's also feasible to give. And then we have more recent data on pomalidomide, also numerous phase 1 and 2 type studies. And the later ones, almost all of the patients had prior bortezomib, and we're seeing response rates again in the 50 to 70% range. So similar to what we saw with lenalidomide and dexamethasone, but I think more data relevant to the patients we're currently treating based on prior therapy. And the median time to progression with IMiD-based therapy is generally in the 1 to 1.5 year range in these studies. So what about other chemotherapy options? I wouldn't be giving a complete talk on treatment of relapse disease if I didn't remind all of us that we actually have pretty long-term data on just bortezomib monotherapy or bortezomib with dexamethasone, very active for patients who previously were treated with transplant, for instance, and then relapsed, and could be a consideration for a patient with relapsing disease in that setting. At this meeting, I think one of the more exciting abstracts that we're going to hear about from Dr. Dispenzieri is the tourmaline AL1 abstract, which is a randomized study of ixazomib dexamethasone versus dealer's choice in relapsed AL amyloidosis, 1 to 2 prior lines of therapy. And dealer's choice could consist of Lendex, Thaldex, Cydex, or Meldex. So all of those are reasonable regimens. So this is real life control arm. The results of the trial somewhat disappointing in that the response rates were not different between the two arms, but all of the time to events, most of them actually favored the ixazomib and dexamethasone. We see here a graph showing that time to vital organ deterioration or death did favor ixazomib, and this was one of the 2 primary endpoints for the study, and other endpoints such as progression-free survival and time to next therapy also tended to run in this direction, favoring ixazomib. We have data on another proteasome inhibitor as well, carfilzomib and dexamethasone. This is a phase 1/2 study from a few years ago, reported by Dr. Cohen. Almost all of the patients had had prior bortezomib, and although there was a pretty robust response rate, there was also a pretty significant rate of grade 3/4 cardiopulmonary adverse events, including 3 patients who had hypertension. And I was thinking about our patient when I was looking at this data, that carfilzomib dex might not be the best therapy for this particular patient. But there is ongoing work with carfilzomib, and I'll show you a case report in a little bit of a patient who got a carfilzomib regimen with some benefit. There's been a phase 2 study of bendamustine and dexamethasone presented by Dr. Lynch. This is a 31-patient study, and the starting dose was 100 milligrams per meter squared for 2 days in a row out of every 28. Response rate was 50%. Progression-free survival was about 9 months. There were occasional organ responses. The toxicity was fairly typical for alkylator type therapy, and about a third of the patients on this study did ultimately require dose reduction. I think one of the most promising things about this particular regimen is simply the convenience of a therapy that you get for 2 days in a row once a month and then can go home and forget about in between. Let's talk about the next option, which was evaluation for high-dose chemotherapy and autologous stem cell transplant in relapsed disease. So I'm showing you data here from the UK National Amyloidosis Center, which compared outcomes in patients who got transplant as part of upfront therapy versus patients who got transplant as part of second-line therapy. And I don't know why I bothered to tell you which line was which, because the lines are superimposed on each other, and so it doesn't really matter which line is which, right? They basically did identical. And what they emphasized in this report was that they probably did identically because the patients were selected with the same stringent criteria, whether the transplant was being done as first-line therapy or second-line therapy. Now, I was surprised that in our group, transplant was the runaway next choice, because I mentioned that the patient was a cardiac stage 3 patient, and in this series, only 5% of the patients were cardiac stage 3. So this data doesn't really represent our patients. But Dr. Hua and colleagues at Mayo Clinic did publish data showing that the Mayo cardiac staging system has prognostic significance when it's used to restage second-line patients like it did in first-line patients, and that actually that scoring is independent of what the patient scored at with first-line therapy. So it brings me back to that point that I made, that we should reevaluate the patient and see if perhaps they're a candidate now, even though they weren't before. I mentioned our patient did have some cardiac improvement, and if her cardiac status did slip into transplantability, then I guess the 60-something% of you that voted for that could be right. That could be a consideration. There is I'm going to mention in passing, there's an abstract from Cornell with 24 patients that sort of asked a similar question to this, and their conclusions were exactly identical to the British results, and that'll be viewable as a poster at this meeting. But I think what we have to ask ourselves is not just, could a patient be a candidate? and is the transplant likely to be as effective as upfront transplant? I think the other important question is, how likely is the transplant to be effective compared to other therapies that are available at that time for that patient? And this data, also from Mayo Clinic, suggests that transplant really is just one of several options that has pretty similar overall outcomes. And this analysis actually is in the pre-DARA era, right? And so if you included DARA with some of these other agents, or included a curve of just DARA-treated patients, you might actually have something that pulls up away from transplant in this. So it's important to remember that we shouldn't feel pressured to consider transplant or stretch the eligibility criteria for transplant just to use it when other very effective agents are available as part of second-line therapy. I just want to show one slide, for informational purposes. If our patient had actually had transplant as part of her first-line therapy, could transplant be a consideration for a second-line therapy? And actually, both Boston and Mayo have published a small amount of data on this, between them just about 20 patients. And I think what this shows us is that, yes, you can collect stem cells in some of these patients. Yes, you can get responses in about 50 or 60% of patients. But the Boston data at least suggested that the duration of response may not be as durable as with frontline therapy. So I want to close by talking about some emerging agents. And as you can see, even with the established agents, it's all phase 1-2 data, except for this recent Exasamib study. And so when we're talking about emerging agents, we're talking about things that have been reported as case reports. Elotuzumab is one example of this. This is an anti-SLAMF7 antibody that we are using routinely in multiple myeloma in combination with IMiDs. It was approved in combination with lenalidomide and pomalidomide because of the improved progression-free survival when you add it to those agents. There's a case report of a 51-year-old woman with kappa light chain AL amyloidosis with renal involvement who had, over a period of 10 years, for the purposes of time, several different therapies, including KRD. I told you carfilzomib can sometimes be used. In 2015, this patient got 8 cycles of KRD as fifth-line therapy, had a partial response, but kept having deterioration of renal function with increasing proteinuria, and KRD was swapped out for ELO-RD, and the patient promptly had a hematologic complete response, and at the time of this publication had been on therapy for 28 cycles. And when we look at the proteinuria, we see that proteinuria was actually at its lowest point at any time along the course of this patient's illness during the time that she was getting ELO-RD, suggesting this was a very effective regimen for her. There is an ongoing multi-center phase 2 study of ELO-RD ongoing right now, this is the clinicaltrials.gov number, so you can find out more information about it. We saw this slide already, actually. This is one case report of a patient who got venetoclax and Velcade in the setting of a T1114 translocation. We know that the myeloma patients with this translocation are particularly responsive to venetoclax-based therapy, probably because of dysregulated BCL2 expression or changes in the BCL2-MCL1 ratio. This is a BCL2 inhibitor. I'm going to skip over this slide and go to a separate case report of a person who was treated with the combination of venetoclax and daratumumab for relapse disease. And what we can see here, at the bottom you see the varying lines of therapy. And when daratumumab was started by itself, we saw an improvement in light chains, but it plateaued at a level that was still somewhat elevated, with persisting proteinuria and elevated cardiac biomarkers. And then venetoclax was added, which pushed the response deeper, and the patient had both a renal and cardiac response and ultimately achieved MRD negativity in this particular case. So both of these case reports, I think, argue in favor of studying venetoclax in AL amyloidosis as it's being studied in multiple myeloma. And Ray Comenzo has had a trial open at Tufts looking at venetoclax and dexamethasone, which I think is on a partial clinical hold right now and is not accruing patients. But hopefully we will be able to get these kinds of protocols back on track for this agent. In closing, summary and final thoughts. There's lots of variability in the timing and rationale for starting treatment for relapsed AL amyloidosis, and it should be considered on a patient-by-patient basis. Effective therapy, I didn't have a chance to really talk about this data, but a cost and resource utilization analysis that was done by a group of researchers, which included Dr. Sanchorwala, suggests that effective therapy for relapsed AL amyloidosis can actually reduce healthcare costs. In that analysis, the monthly cost of taking care of a patient with relapsed AL amyloidosis was $15,000, and 2/3 of that was managing the medical complications of the patients because of their amyloid-related symptoms, and it was not medication costs. And particularly because right now in amyloidosis we don't use maintenance therapy, right? We don't use maintenance therapy. The place where we can really make an impact is eliminating those medical complications by getting better disease control. Now, maintenance strategies, trials like some of the ones we've heard about, or ongoing use of antibody therapy over time might undermine this analysis a little bit because the drug costs will definitely go up if we start using maintenance strategies in amyloidosis. Daratumumab-based therapy alone and possibly in combos is very effective, and we're going to probably be using it up front soon, and we're going to need to figure out how to use it in the relapse setting after that. Other myeloma drugs have utility, but it's important to recognize that some of them, like carfilzomib, may be more toxic in amyloidosis patients, and same is true of other more commonly used ones like lenalidomide, which can't be used at full dose, or dexamethasone, which is routinely started at a reduced dose in patients at older age or with cardiac involvement or edema. And finally, clinical trials should always, always, always be a consideration if we're going to move this field forward. I'd like to just end in my last 50 seconds by thanking several people. First, Silva Preja, who keeps everything running at Karmanos with our plasma cell team, but also was really responsible for virtually everything that went on with this symposium. And Silva, thank you, Falam Derrit, for all the work that you did on this symposium. Other colleagues who are part of our myeloma team who were also helpful putting this particular day together, and all the people in clinic who help take care of our patients and are so important, particularly for our patients on clinical trials. Finally, the generosity of the McDevitt, Silver, and Ring families who have provided really great support for our program over the years. And then also amyloidosis support groups and the Amyloidosis Foundation, both of whom directly supported this symposium. Those two organizations, plus the Amyloidosis Research Consortium and the Multiple Myeloma Research Consortium, who do so much to advance research in plasma cell dyscrasias. Thank you. Our next speaker, and I don't want to set expectations too high, but our next speaker, Martha Grogan, is coming from Mayo Clinic. She's a cardiologist. She's going to be speaking on managing cardiac complications of AL and ATTR amyloidosis. So we're going to be expanding our topic a little bit. And I have to tell you, her slides are absolutely amazing. This is going to be a great talk.
Thanks so much to the organizers. It's really exciting for me to be here at a hematology meeting, and I think more and more you're going to see cardiologists at hematology meetings and vice versa, because we're really even more entering into a multidisciplinary area. So here are my disclosures. And for this talk, what we're going to talk about are the three main complications of cardiac amyloidosis, which are very familiar to the group: heart failure, arrhythmias, both tachyarrhythmias and bradyarrhythmias, and conduction system disease, and sudden cardiac death, especially in the AL patients. And I have to tell you, all of these are very, very tough to manage. So this is really a hard talk. Most of the time when I speak about cardiac amyloidosis, it's to cardiologists trying to raise awareness and get an accurate diagnosis. But managing these complications is really challenging. And as this group knows, for AL amyloidosis, of course, the mainstay is treatment of the underlying disease. And as cardiologists, we play more of a supportive role and very difficult at that. Now with TTR amyloid, we're in the advent of therapy, so we have the ability to really impact maybe even the development of heart failure in these patients. So very exciting, but still a very difficult topic. Now, one of my favorite things that I discuss with patients, and I thought as hematologists you might like to hear this too, is just highlighting ejection fraction. So remember that ejection fraction is a percentage. So I made these graphics, and they're actually online. We actually have a Mayo Clinic amyloid YouTube channel, believe it or not. We have about 13 videos on there, which include several on cardiac amyloid. So I use these with my patients to try to illustrate cardiac function, and I think it's helpful for hematologists too. So just remember that ejection fraction is the percentage of blood that's ejected with every heartbeat. But if the heart doesn't fill very well, as in amyloidosis, the ejection fraction can be normal or low normal, and really the cardiac output is significantly reduced. So just to highlight that the main issue with cardiac amyloidosis is a loss of elasticity of the heart. So the heart, after systole, should relax in diastole and be able to really truly suck blood into the heart. And that's why athletes can increase their cardiac output so much, because their hearts are so elastic. So the ejection fraction, if it's normal, that's not necessarily reassuring, and you all know that in cardiac amyloid. The stroke volume and the stroke volume index and cardiac output may be very severely impaired. In addition, the heart function is really very complex. And if you look at an echo report, you'll see about 100 different numbers. So we don't have a single number that tells us how the heart is doing. However, when you hear that heart failure is the inability of the heart to pump enough blood to meet the body's demands, then it makes sense that you hear ejection fraction is the percentage of blood pumped. It seems like ejection fraction would tell us the answer, but as you know, it doesn't. The other thing I want to highlight is that in amyloid patients, because the ventricle is small, even a small change in our measurement may lead to a relatively large change in ejection fraction, even in situations where there may not be a significant change in the overall heart function. So there's really more room for error in amyloid patients. So I must say, when I go in to see a patient, I usually have reviewed a lot of things in advance, their outside records. The nurse gives me some idea about their symptoms. I know their family history. I've looked at all the tests we've done. I've literally just looked at their echo. And I know the strain, I know the EE prime ratio, I know how the IVC looks, I know the estimated right ventricular systolic pressure, I know the wall thickness, I know if the right ventricular walls are thick, what the RV function is, and then the patient says, "What's my ejection fraction?" And I look like this really dumb doctor, because I go, let's see, what did we report it? And I literally just looked at it. So I make the case to you that EF is close to useless in amyloid. Now, that's a little exaggeration. We do want to know the ballpark. Is it 10 or 25%? Those really low EFs are obviously associated with poor outcomes. Is it 25 to 45, or is it more than 45%? So I just kind of caution you, that's the spiel that I give to the patients. And these minor changes in EF often don't mean a lot. One thing I've learned over the years of working with the hematologists a lot is that hematologists love numbers. And their numbers are actually pretty darn accurate. And of course, what's one of your major diseases? It's anemia. You've got hemoglobin, hematocrit, all kinds of other ways. But you have everything you have is a count, right? So the hematologists appropriately have learned how to apply those numbers to cardiology, primarily with the biomarkers, which are very, very powerful. However, cardiologists love pictures. Now, with our pictures, sometimes we put numbers like ejection fraction, like strain, but they're really a lot more gray zone than you would think from those reports. In fact, even if you look at coronary disease, Oh, we say that the LAD stenosis is 80%. Different cardiologists looks, oh, no, really, it's probably only about 50%. So our numbers are really not as precise as yours. So I've thought this for quite a while, but recently I noticed I felt terrible that I missed Jeff's journal club. So those of you who aren't on Twitter should get on Twitter. There's so many fun things and informative things happening. But just last week, there was a amyloidosis journal club. So I thought, let me go see what I missed. And here's what I saw when I tried to figure out the article. It's actually Dr. Mukhtar's article, by the way, so he needs to get on Twitter. And here's what I found from Vaishali. This is what I found when I wanted to see what happened at that journal club. I have no idea, but it proves my point that hematologists love numbers. I couldn't figure out anything from that tweet. So, but there are, if you're going to look at numbers, there are some numbers that probably might help you a little more with your amyloid patients that you don't think about. So stroke volume and stroke volume index are calculated on most echo reports. And the stroke volume is the actual volume of blood, not the percentage, but the volume that's ejected with every beat. Then the cardiac output, of course, is the stroke volume times the heart rate. So that's a pretty important number. And most of the time will be calculated, and then you can index the stroke volume for the patient's body surface area. So this is actually the stroke volume here. This is the amount of blood that was filled in diastole. And if we look at this animation, you'll see the heart filling with blood here. So here you're going to see the diastolic volume. Then, and we did this as kind of balls of blood to make sense for our patients. And then you see the actual amount that was ejected. And so this is the actual stroke volume right here. And then we can calculate the ejection fraction, and we do it by volumetric techniques and other techniques, but just showing you the difference between the stroke volume. And this would be an amyloid patient with a very small ventricular cavity. So you might have a reasonable ejection fraction, but a very low stroke volume. And Dr. Milani, who's in the audience, looked at the overall survival according to stroke volume index in patients with AL amyloidosis and noticed that the stroke volume index of less than 33 was a very good discriminator of prognosis. And this is independent of EF, of blood pressure, of biomarker stage, and even LV strain. It actually performed as well as LV strain, so in labs that don't have strain readily available, and there are some issues with reproducibility of strain as well. So it's a pretty simple predictor of outcome. But again, you have to make sure that it was done in an accurate manner, and there are some technical reasons. So really, I want you to take the whole echo in context or your whole cardiac evaluation in context, but this is one number that can help you. Another reason I mention it is, this is the reason it's so hard for us to manage patients with cardiac amyloid, because they have a low stroke volume usually, a fixed stroke volume, no ability to adapt. So heart failure is very difficult to manage, and arrhythmias are very difficult to manage. These patients are really literally the ones with significant cardiac involvement. They're walking on a tightrope. And if you have them right in the middle of the tightrope and you have everything balanced, they're not necessarily good, but they're kind of okay. But if anything tips them out of balance, they fall off that tightrope in a big hurry. And that's why it's so hard for us to manage these complications. So when we think about what we have, it's not that we're bad cardiologists. If your cardiologists aren't making a lot of progress with your patients, it's because it really is the toughest form of heart failure for us to treat. So obviously, the prime treatment is to stop amyloid production. For diuretics, there's a few tricks, and for most of us, we will use torsemide because the bioavailability and the consistent absorption is better in our patients. So that is something that switching to torsemide may often help you compared to furosemide. The aldosterone antagonists are very helpful in preventing hypokalemia and do provide some additional diuresis. So we really want to keep potassium above 4 whenever possible to help minimize arrhythmias. A kind of simple thing is using compression garments, because what I tell patients is we want to use every mechanical means to mobilize fluid and to try to minimize our diuretic dose because of some of the complications, especially in these patients who are prone to hypotension and renal disease. And then again, we have this tightrope of heart rate. So most of our amyloid patients, the ones that are pretty advanced, if anything, are going to need a little higher heart rate. So if you lower their heart rate to even what cardiologists are usually targeting, they may be in big trouble, especially if you do it in a way that's irreversible. So patients can suffer from both just a little bit of tachycardia or even a relatively small amount of bradycardia. And then you want to make sure you've treated sleep apnea and any other aggravating factors that might be making their heart failure worse. I do think cardiac rehab, especially recognizing that we're not going to push these patients real hard, but that's the importance of having monitoring and some light strength training, is helpful for our patients who are compensated enough to do so. And especially when we talk about the TTR amyloid patients who often do have a longer survival, the importance of not only aerobic but strength training can become quite evident. So we have a lot of studies in the heart failure world highlighting to us that heart failure doesn't just happen at the level of the heart. It's what's happening in the systemic vascular resistance and the periphery. And one of the things is metabolically, muscle is much better than fat. So for all of our patients, I really tell them that in the cardiology world, maybe we've emphasized aerobic exercise a little too much to the general public, and strength training is very helpful if done cautiously and with a low amount of resistance. So what I tell my patients is the heart really likes to pump to muscle, not flab. So I get them doing a little bit of strength training. Many of you know that especially AL patients, particularly early after the diagnosis, really do not do well with standard heart failure treatments. Beta blockers, ACE or ARB, and Entresto, and those are almost always contraindicated, again, especially early after the diagnosis. There might be a role in some of our very chronic patients that we actually do see chronic AL cardiomyopathy now, I'm happy to say, because of all your advances, and that might be a little bit different. But cardiologists will often start these on your patients because they're trying to do what the right thing is for heart failure. And of course, they get all those little warnings in the EMR. How come you didn't put the patient on ACE inhibitor, beta blocker? So just make sure you convince your cardiologist not to do that and just to check not applicable on that epic warning that they get. You do not uncommonly face patients with cardiac amyloid who have reduced ejection fraction, both AL and TTR. But again, the reverse remodeling that beta blockers and ACE-ARB inhibitors are so beneficial in other types of heart failure really don't apply to patients with an infiltrative cardiomyopathy, and especially beta blockers, particularly Coreg, because it has alpha blocking characteristics, is particularly difficult. What about circulatory support devices? So the role for these might expand as the devices improve. The key challenge is that most of these patients will need biventricular support. So a left ventricular assist device doesn't work very well with a small, thick heart. And that's because we put a cannula in the LV apex, and there is this suck down effect, it's called, where as the blood is being sucked out into the device, the thick ventricle literally just collapses around the cannula and obstructs flow. The right ventricle is often abnormal, so these patients usually need biventricular support. Organ transplant is an option in very highly selected patients. For most AL patients, most centers will require that the patients have primarily cardiac involvement and very limited extracardiac involvement. You'll see a range of which centers are willing to do AL patients, and you might see a little trend where they'll do some and then they stop doing them. The role, unfortunately, we're often diagnosing these patients too late, but for highly selected patients, organ transplant is a possibility, and especially ATTR patients are increasingly being diagnosed, especially the wild type patients, in their 60s. And they are often, if they have advanced heart failure, they can be very good heart transplant candidates. So they usually have had very few other medical problems before they get amyloid. So here we'll talk about a patient, a 55-year-old, who noticed some palpitations while he was running. And he had not been on his program quite as much recently, so he thought maybe he was deconditioned. He had a stress test that was negative for ischemia, but he did have some non-sustained ventricular tachycardia on the stress test. About 6 months later, he still wasn't really feeling right, and he finally got an echo. He was diagnosed with non-obstructive hypertrophic cardiomyopathy. His EF was 65%. He was started on a beta blocker, and it was recommended that he get family screening and genetic testing. And he still wasn't really feeling too horrible, but he wasn't able to really run the way that he thought he should. So 9 months later, a new cardiologist came to town, took a look at the echo and said, I don't think that's hypertrophic cardiomyopathy. I think you may have amyloid. But for some reason, it took 2 more months to get a cardiac MRI. And that was poor quality and indeterminate for amyloid. Anybody know why it was indeterminate? Because one of the problems in amyloid is that the myocardium does not null with gadolinium. So it's was actually classic for amyloid because you really can't see the heart as well as you should because of that difficulty nulling. So then 13 months into this saga, he happens to go see a urologist because he had kidney stones back in the day. And the urologist says, you've got some proteinuria, you better see an internist. And then at 15 months, he gets a light chain assay. So I don't have to tell this crowd that this is way too long. It took him 17 months before he actually got diagnosed with AL amyloidosis with cardiac and renal involvement. And here you see the lambda. We have milligrams per deciliter, but 7.08 milligrams per deciliter, ratio 0.04. His troponin and NT-proBNP were both elevated, and he had significant proteinuria. So that was way too long. I didn't include biomarker staging for AL because I think you all know about it, but obviously this is a patient we would have wanted to pick him up back at the time of that first echo or even earlier. So during chemotherapy, he developed some heart failure. Now, he really did not have overt heart failure before, but his NT-proBNP went to almost 8,000. He had stem cell harvesting, and he developed some pulmonary edema, although he responded pretty quickly to diuretics. He developed atrial fibrillation with rapid ventricular response, and he happens to already be on anticoagulation due to a DVT. So here we'll use the audience response, and I wonder, now your cardiologist says that he needs a cardioversion, and so what are you going to recommend for this patient? So should we go ahead with the cardioversion? Should we do a TE-guided cardioversion? Should we do amiodarone followed by cardioversion? Or you're going to be honest and say you're not really sure what to do with this patient? I think we have very honest hematologists here. They're probably more honest than most cardiologists, would never admit that they are not sure of something. So, okay, so people are not really sure what we should do with this gentleman. And I mentioned that these atrial arrhythmias are so difficult. If you're going to do a cardioversion, which is not unreasonable for the first episode of atrial fibrillation, I'm going to make the case to you that I really think it's important for you to educate your cardiology colleagues that you need to do this with TEE guided. And here's a paper that we wrote about TE cardioversion in patients with cardiac amyloid. We've known for quite some time that patients with any type of amyloid, but especially AL, have a very high risk of intracardiac thrombus. Here you see a patient who died of a stroke who never had any documented atrial fibrillation. Those were the earlier studies from our institution and others. And we recently looked at our experience of patients who came for a TE cardioversion, and we found that almost 30% of them were canceled. Most of those were because they had an intracardiac thrombus. And of those patients, almost half were either on anticoagulation or had short duration of atrial fibrillation. Importantly, when we cardioverted them, 14% of patients had complications. And these were not minor complications. These were VT, VF, bradycardia requiring pacing, or a stroke. Now, one of my colleagues said, well, that's not a big deal. You guys are used to dealing with this. I'm like, no. When we do elective cardioversion, we are not expecting those things. And in fact, our controls had a 7% cancel rate, but most of those were because they spontaneously converted the sinus rhythm, and they had only very minor complications, usually self-limiting bradycardia. In addition, when we looked at these patients later, only 43% of the patients with cardiac amyloid had resolution of their thrombus at 6 months versus about 83% of the control. So we've seen this clinically, that once these patients develop a clot, many times the clot persists. It's probably not an actual failure of the anticoagulation, but it may be not only the degree of stasis of the atria, but also local factors in the atria and the fact that the patients have a tendency to be more hypercoagulable. So we've convinced cardiologists that they should do a TEE before they do a cardioversion in these patients. And if you look at Holter's, whether you have non-sustained ventricular tachycardia or atrial fibrillation in a group of patients who had Holter's is associated with adverse outcome. But if you looked at a routine group that we had that were undergoing stem cell, it really did not impact their peri-transplant mortality when adjusted for Mayo stage. So usually, I'm not a big fan of the routine Holters. It just makes me more nervous. But if you found AFib, you can give them anticoagulation cautiously, so that might be one role. So back to our patient. He had CyBorD chemotherapy, got a complete hematologic response at 9 months. He was definitely feeling better, working full time. But look at this, his NT-proBNP went to almost 8,000 after 2 cycles. 9 months, it was better. And actually now, he's about 15 months after his initial treatment, and he's been off of treatment for 3 months because of his complete hematologic response. And his biomarkers are now less than they were at baseline. So he's starting to show some evidence of cardiac improvement, and he's actually eventually had some renal response. But just thinking about this patient highlights that there are cardiotoxicity of your drugs, and you know that. Jeff also talked about that. So it can be hard for us to know when the patient's getting worse. Is he truly getting worse? Do we have organ progression? Is it the chemotherapy? Is it the steroids? Is it the atrial fibrillation? And there's not an easy answer to that. But in this patient, once he's off of chemotherapy, he's clearly getting better. So when we think about these arrhythmias, they have a very narrow range of heart rate. Most of the time, you're not going to do an urgent or emergent cardioversion. And you should really think about the lesser of the evils. Beta blockers at low dose, we often have to use for atrial arrhythmias, but higher dose are problematic. And in the interest of time, I won't go into the whole digoxin controversy, except to say that it was mostly in vivo. Never any evidence for the TTR patients that it was bad. And probably at low dose, digoxin might be preferable to amiodarone. Amiodarone does have a black box warning. It has a lot of bad things that can go wrong with it. So I included, I'm going to go through this quickly in the interest of time, but I think you want to use the lowest amount of beta blocker. You can consider DIG for these atrial arrhythmias. Amiodarone, if you're just using it for rate control, is a complex medication, especially if you're going to transition the patient to long-term oral amiodarone. It's also really not that great at converting patients, even though the ICU doctors will always tell you we gave amiodarone to convert the patients. But if you look at the studies, it really doesn't have that high of a rate of conversion compared to placebo. And just remember, if you give amiodarone, especially orally, it's going to take months for you to get that amiodarone out of the patient's system. So these AL patients especially are at risk of thyroid disorders and other complications. ICD, just to highlight that in AL amyloid, most of you know that the studies have been mixed, but there actually was one prospective study, and notice that 7 of the patients died of pulseless electrical activity, previously called electromechanical dissociation. So we don't really know, except for that many patients, especially with AL, will die despite an ICD. We really don't have enough information to say that we should use those for primary prevention, but we might consider them for patients with unexplained syncope, and we do use them for secondary prevention. So I'm going to just close a little bit with TTR amyloid. Looks like I'm slightly over, so I'm going to talk a little faster. But just to let you know that wild-type TTR amyloid is everywhere. So we've known from autopsy series that as people get older, it's common, originally thought to be incidental. But now we see with carpal tunnel syndrome, when it's bilateral, men over 50, women over 60, this is really not an uncommon disease. HFpEF, 13% of patients may have wild-type TTR, and that's half women. One of the most shocking things that you'll hear is spinal stenosis. There have been studies showing 100% of patients with spinal stenosis have amyloid. and half of those may be wild-type TTR. Now, those are being confirmed in larger studies, but it is a lot of patients. So everybody really needs to know about this, not just cardiologists, but hematologists all need to know about TTR amyloid. And how can you miss it? Because the patient's going to come into your office looking like this. So if the patient looks way better than the echo, they have TTR amyloid. If the patient looks a lot worse than their echo, then they have AL amyloid. So I'm just, Jeff, do we have a few minutes to talk about PYP? Because I'm a bad person.
Absolutely.
I'm running a little
late.
late.
A few extra minutes built in. So
Oh, good. I'm not going to get the hook. So PYP scanning is really an important new tool, but it raises some also significant concerns. It's been a revival of nuclear cardiology. So technetium pyrophosphate lights up basically in the hearts of patients with amyloid, especially TTR amyloid. But one of the challenges that we've had is that some people have missed the memo, cardiologists especially, that you have to exclude AL amyloid when you're doing a technetium pyrophosphate scan. And you also have to make sure that the uptake is actually in the myocardium, not just in the blood pool. So this is what you would see on a SPECT image. So this is a planar imaging, so you see uptake on the left side of the chest, but that could be bone, blood pool, something else. You really want to see, is it actually in the myocardium? And why is that so important? Because as you all know, now we have tafamidis to treat TTR amyloid with a 30% reduction in all-cause mortality. And the number to treat is really very, very reasonable. So this is an important new drug. And you know that we also, you're going to hear about silencers and other options. But for cardiac right now, the drug that's approved is tafamidis. There are other silencers, and so I just, other stabilizers, so I just highlight that diflunisal is also a stabilizer, of course, and AG10 is in clinical trials. But back to some of the issues with PYP, there are some perils, and I'm just going to show you 3 really quick patients. Here's a 66-year-old who had dyspnea and a renal infarct. Echo and MRI suggested amyloid. His PYP was strongly positive with SPECT uptake. He started tafamidis, but he never even had free light chains. So he had markedly elevated free light chains, a lambda monoclonal protein, and the cardiologist ordered a serum protein electrophoresis. He might have even ordered it with immunofixation, but many labs only do the immunofixation as a reflex, or it just doesn't get ordered. So this is a really scary thing. This patient is now on chemotherapy, and fortunately he is responding, but he had several months delay. Here's another patient I just saw who had a dilated ventricle. His walls really weren't that thick. He had a bicuspid aortic valve with aortic regurgitation. PYP was positive, but it turns out he has a flail aortic valve, a torn leaflet of his aortic valve. And it's just planar positive because he has a big left ventricle with aortic regurgitation. So the blood is going backwards, so you're going to have more technetium pyrophosphate hanging around there. So this is another planar positive, SPECT negative patient. And then we just saw a patient referred for transplant that somebody decided to put on tafamidis, and it's just a big heart with blood pool uptake. So these are 3 patients. I saw 2 last week, 3 within the last couple months. This is just me, my little experience, and this is how much that would cost. So major problem. So PYP really is a great test. I don't want you to think it's not, but know that it was done in patients with a high pretest probability of having amyloid, and that's what led to our consensus document. Patients are really supposed to have typical echo and or MRI features of amyloid and heart failure in order to use PYP and the absence of a monoclonal protein. So make sure that your center is doing SPECT CT. Be careful of the planar imaging. I think we should really make that no longer acceptable. And make sure that your cardiologists know how to screen for AL amyloid. There are a few other causes of uptake, plaquenil toxicity, renal failure, myocardial infarction. So I don't think we need to panic yet, but this is probably the most scary thing I've seen in the last couple of months. So managing complications, the key, of course, is going to be earlier diagnosis and treatment. Worsening heart failure in an AL patient might actually be treatment toxicity, and increase in the biomarkers doesn't always mean that the heart got worse. I think I hopefully have convinced you there's a high risk of intracardiac thrombus, so if somebody's going to cardiovert your patient, make sure that they have a TE first. make sure that everyone knows how to use PYP. And more than ever, now we're really going to need this multidisciplinary team to make sure we have accurate diagnosis and management. So you're all going to be seeing more amyloid because the cardiologists, as they look for TTR, are going to find more AL, and everybody in this room is going to be busy. So thanks very much for your attention. Okay, so it's my pleasure to introduce Dr. Comenzo from Tufts, who's the director of the myeloma and amyloidosis program there. And he's going to talk to us about novel agents for amyloidosis, RNA interference, and monoclonal antibodies. Welcome, Ray.
Thank you, Martha. And I'd like to thank the organizers for the opportunity to speak with you this morning about these new agents that have been developed to treat systemic amyloidosis. These are my disclosures. I'll follow this simple outline this morning, covering the highlights of these classes of agents and some of the clinical benefits. I'll also present preclinical data on novel agents that may be part of future therapies. As everyone knows, the two most common types of systemic amyloidosis are ATTR and AL. ATTR can be hereditary or wild type. ATTR-M, the hereditary form, is caused by one of over 100 mutations in the TTR gene, resulting in more rapid dissociation of the tetramer into 4 monomers. In AL, as in ATTR, there are cellular and extracellular phases of protein production and disease pathophysiology. RNA interference deals with the production phase, and monoclonal antibodies can deal with the cells as well as with several extracellular phases. ATTR, as you all know, is a disease in the hereditary form that has a variable mix of cardiac and neurologic symptoms. In both instances, it is a progressive disorder and can cause significant disability, wasting, intractable autonomic neuropathy, and end-stage heart disease in less than a decade after the onset of notable symptoms. At the same time, even in areas such as the US, where the African American population has a prevalence of 3.4% of isoleucine 122, and in areas like Portugal, Japan, Scandinavia, and County Donegal in Ireland, where the prevalence ranges from 0.1% to 1%, the penetrance is not well defined. ATTR wild type is a clinically similar but somewhat different disease. The connective tissue involvement with biceps tendon rupture and spinal stenosis, and we have over 300 cases, which we'll be presenting in Tarragona, of patients with spinal stenosis whose ligamentum flavums were stained with amyloid. The percentage of amyloid is around 20%. It's not 100%. If it were 100%, the country would be spending $20 billion on surgery for spinal amyloidosis, and corporate interests would peak notably. In any case, it is likely the cause of HFpEF, as Martha said, in 10 to 15% of patients with HFpEF over the age of 75, equally distributed among men and women. Most of TTR is produced by hepatocytes, the cells that are shown on the slide. And normal TTR is a chaperone protein for vitamin A and thyroid hormone. This schema depicts the dissociation of the tetramer into monomers, and the monomers are the vector of ATTR amyloid. It also shows the misfolding, the oligomerization, and the beta fibrillation stages. The cause of AL is misfolded free light chains produced by clonal plasma cells. Normally, within plasma cells, light chains are produced in slight excess of heavy chains because unpaired heavy chains are not secretory competent, and within the plasma cell can misfold and trigger an unfolded protein response that can be terminal. Light chains, in contrast, are secretory competent, and in normal persons circulate at levels of up to 25 milligrams per liter. A functional physiologic role for circulating normal light chains has never been defined to this time. In AL, there is obviously lambda predominance, and as Dr. Schoenlund showed, a predominance of the 11-14 translocation, resulting in loss of the heavy chain and hence light chain disease. And also in some cases, loss of a microRNA cluster that's probably important. This results in loss of the, and although the entire light chain, the variable, the joining and constant region can be involved in amyloid beta fibrillation. The small number of light chains that are more prevalent in AL than in myeloma demonstrate a pattern of organ tropism that has been described in other plasma cell diseases. RNAi aims to stop translation, stop protein production. In ATTR, the culprit protein is obviously transthyretin, and in theory, in light chain disease, it could be the free light chain genes. These agents are highly specific, and the activities, the different half-lives, the rates of decay of messenger RNA within cells are extraordinarily complex and important features of cellular metabolism. RNAi takes advantage of two of these major degradative processes. For antisense oligos, say 20 nucleotide stretches of the oligo include flanking portions of RNA nucleotides and a mid portion of a DNA stretch of nucleotides. This agent binds to messenger RNA, creating a hybrid. And that activates one of the major degradative processes intracellularly, RNase H1 degradation of the hybrid. This is sort of like the state police, maintaining homeostasis within the cytoplasm with respect to translation. I compare the formation of the RNA-induced silencing complex to the FBI. So siRNA is a double-stranded RNA molecule that separates in the cytoplasm. The sense strand binds to an appropriate risk and triggers degradation of the message that is its target. However, there are many challenges for RNA interference. Getting from outside the body into the circulation and to the target tissue is particularly challenging. There are nucleases and proteins in the circulation that rapidly degrade circulating nucleic acids. Many vehicles and many modifications have been used over the years to try and solve this problem, and it turns out that lipid encapsulation is likely the most effective way we currently know to solve the problem of delivery. At the same time, encapsulated RNAi agents in lipids are more likely to go to the liver, and hence the focus on liver diseases such as TTR amyloid and porphyria. It's very important to understand that the next phase, once the lipid has entered the cell, is also very complex and requires trafficking within the cell to the appropriate degradative sites. And that's an issue that's been worked out empirically by the commercial entities. Inotersen is an ASO, and it's approved for the treatment of hereditary amyloid with peripheral neuropathy. It was developed and approved on the basis of a phase 3 randomized trial. A validated peripheral neuropathy instrument, the NIS+7, was used to define the primary endpoint. Quality of life instruments were used to define the secondary endpoints. Prealbumin, the tetramer of TTR, was also measured, and cardiac measurements such as wall thickness were used as well as correlative endpoints. So Interestingly, the patients who received inotersen, over half of them had reductions in prealbumin, so they had reductions in TTR. The secondary cardiac endpoints, by and large, were very excitingly met. And the evidence for impairment of progression, reduction in progression of cardiac amyloid, the evidence was quite strong. However, there was a 22% withdrawal rate in the inotersen arm, an 8% in the placebo arm, mostly due to adverse events and progression of disease. There was a 3% of incidence of glomerulonephritis in the inotersen arm, and also more frequent thrombocytopenia of all grades. There were 5 deaths in the study, all in the inotersen arm, and one of the deaths was due to intracerebral hemorrhage in a patient with grade 4 thrombocytopenia. The drug is approved. It's given subcutaneously on a weekly basis. Patisiran, a second RNAi agent that is an siRNA agent. It's given every 3 weeks IV as a stable nucleic acid encapsulated lipid particle. The cargo is the siRNA against TTR, the TTR message. In the phase 3 trial that led to its approval, the same instrument to score peripheral neuropathy was used, the NIS+7, and quality of life instruments were also used for secondary endpoints. The withdrawal rate was 38% in the placebo arm and 7% in the patisiran arm. There were infusion reactions that were generally mild in 20% of patients in the patisiran arm. The graphs that I show here are very interesting. The graph on the left shows that the TTR level measured as prealbumin is actually significantly lower in those who got patisiran. However, not all of them had improvements in NIS+7 scores. That means that you can't use the prealbumin level as a marker of response to patisiran. You have to use the patient's clinical status. Cardiac improvements also occurred in the subset of patients with cardiac disease. This agent is approved and, as I said, is given every 3 weeks intravenously. This patient came to me late in 2017, quite a history of atrial fibrillation. He developed orthostatic hypotension that dramatically affected his golf game and had a family history that was interesting. He was of Irish descent. His grandfather died of amyloidosis in County Donegal. We diagnosed the ALA60 very quickly. Fortunately, there was a trial available for him, the PRX004 trial, which I'll mention shortly. He enrolled on the study. He tolerated the agent at the lowest dose level. Obviously, he was first patient in. And then went on to receive patisiran once it was approved. His prealbumin level went down immediately on patisiran and it stayed low. His orthostasis essentially resolved in about 6 to 8 months. His atrial fibrillation remained a problem. He had an ablation and a dual chamber pacer placed, which in one instance in the past 6 months has turned out to be life-saving. He also had really massive diarrhea when we diagnosed him. That has largely resolved now at 18 months, although he still has bad days. He'll have a bad day every 6th or 7th day. The graph on the bottom of the slide shows what has happened to his vitamin A level. Obviously, it's gone down with the suppression of circulating prealbumin. So he's on supplemental vitamin A, which is a necessity. So with the success of siRNA technology, we decided to try and knock down light chain production. We have a bioengineering collaborator who's been working with us. We've designed siRNAs for the constant region of the kappa and lambda light chains. We can deliver the siRNA successfully in vitro. The top left-hand slide shows labeled Cy5.5 siRNA that has been delivered into plasma cells, we can successfully knock down intracellular light chain in patient cells. The middle slides on the top. And the far right slides show that we can knock down production in vitro with siRNA directed at the constant region of the light chains. So we developed xenografts in NSG mice using 2 myeloma cell lines. The xenografts engraft very quickly, very short latency period, 12-day latency period, which is very important as you're trying to develop effective technologies. The cells are intraperitoneally injected. What you see in the lower left is an image of the mice at 12 days and an image of a liver section from one of the mice showing the CD138 positive human cells. The image in the middle on the bottom is an image of the lipidoid nanoparticles, which are injected beginning on day 5. And what we see is that by day 8, in these rapidly engrafting human myeloma cells that are highly productive of light chains, that we can mute the production of light chains in a 3-day period. One of the interesting things about these reporter cell lines is that we can correlate light chain production with the bioluminescent signal and with soluble BCMA, which I'll say a little more about in a second. So we've got numerous ways of assessing tumor burden. Which brings me to monoclonal antibodies. The other class of agent that has great relevance to systemic amyloidosis. From suppression, therefore, we go to scavenging. I'm going to talk a little bit about monomer scavenging, and I'm going to talk a bit about fibril targeting. But what's interesting about monoclonal antibodies is how sophisticated the universe has become. Monoclonals can target cells, they can target proteins, and now we know they can target infectious agents. The success of monoclonal antibodies in treating Ebola is really astounding, truly astounding. One thing that we know is that in the setting of RNAi, the lipids, the coating, the design of the agents within the lipid capsules, all of those elements give a variability which allows for the development of intellectual property, which allows companies to become interested in things because they can patent unique formulations. The same applies to monoclonal antibodies, as this sketch suggests. There are ways to mix and match elements of immunoglobulins that can be uniquely used and may be of great benefit. Etanercept comes to mind. Etanercept puts the receptor for a cytokine, 2 of the receptors, on an FC portion of an immunoglobulin. And it's FDA approved and it works. And the technology itself, evolving from hybridomas to phage display libraries, to humanized mice. It's created a global commercial effort that is really, really extraordinarily beneficial for humankind. But there are still challenges, and amyloid obviously provides major challenges for the application of monoclonal antibodies. XO4 is an anti-TTR monomer, and it's in clinical development. We had the first 2 patients on the study. The trial has moved along. It's a phase 1 study. Radhika is available to you if you're interested in where it is and whether there are slots open. But one of the unique aspects of hereditary TTR, as this gel from Lorraine Connor's lab at BMC shows, is that you can see the lower band. That's the wild type monomer. It's migrated to this isoelectric neutral point in the gel, and all of those bands are at the same level. The mutant form of the monomer migrates to different levels. And this is probably why there's no lab test for the mutant TTR monomer available to us. The suppressors have prealbumin as a readout for efficacy, but agents directed at the TTR mutant monomer do not have an assay available to them. We're really hopeful that as a result of this trial and the work of Prothena in this area, such an assay may be developed. And of course, there's KAL101, the anti-amyloid antibody that's still standing. It's very promising, and I do think that excitement exists at the fact that Alexion has confirmed they will be conducting a clinical trial. Hopefully, we'll be starting next year in patients with advanced AL amyloid. It'll be an advanced stage trial, we hope. And as you know, this antibody was first produced in Dr. Solomon's lab and was tested clinically in a phase 1 trial by Dr. Lynch at Columbia. The trial that Alexion plans will accrue a couple of hundred patients, and we certainly hope that it gets underway soon because patients need to have this question answered. As you know, the history of this antibody dates back a decade. The image on the left of this slide was on the cover of Blood in 2010, and it demonstrates that the antibody binds to amyloid in organs. The images in the middle show that it can activate resorption of amyloidomas, these surrogate tumors in mice. And the image on the right is from the clinical trial, showing that use of the agent may have a cardiac benefit in improving global longitudinal strain. And we move now to a look back at the ride Prothena gave us with D1, and it was quite a ride. D1, as everyone knows, is no longer in clinical development. We hope that the biobank and the control arm data from the D1 trials will be made publicly available, and that productive efforts can be made to learn from those data. The preclinical data for D1 were robust, but not as robust as the KAL101 preliminary data. Wagner Zago for Prothena showed that D1 did bind to soluble aggregates in vitro and had a lovely motion picture showing that with a macrophage cell line, opsonized amyloid aggregates could be phagocytized. Very, very exciting little movie. In the phase 3 VITAL trial for newly diagnosed AL patients, a trial that was halted because of futility, there was the hint of a benefit based on the hazard ratio. And when subset analysis was done, and this is published now, what we saw in the stage, the Mayo stage 4 patients, these are patients with stage 3 cardiac and very elevated light chains, was an apparent survival benefit. Those who got CyBorD without D1 had the typical 6-month median survival. Those who got CyBorD with D1 had improved survival. Very suggestive data. Dr. Gertz has a poster, number 3166, describing this data, and I do think it's well worth looking at. When I saw this data initially over a year ago, I said, well, D1 must be sopping up the aggregates in these patients because they have so many light chains. That is a total speculation. Some might call it an hallucination, but that was my explanation for it. When we looked at the code and broke the code and identified those who'd gotten D1, we learned that we had treated a small number of patients with both D1 and daratumumab. And these data are being published. They'll be out within days to weeks. And what we knew at the time was that daratumumab was very active in myeloma. It had been approved in November of 2015. We didn't know whether or not it'd be active in AL, but it made sense to use it in patients who were very sick and getting sicker. The Andromeda data that Dr. Zonder referred to is shown on the left in the bar graph. And the data on this small cohort of patients who got dual monoclonal antibody therapy is shown in the other sketches. Of particular interest to us is a single case, the free light chain response, the cardiac response in the lower graphs. This was a patient who started with an NT-pro just under 8,500, a free lambda just under 1,000. Both rose, as you can see, in the early phases of treatment. And then with the administration of daratumumab, both came down relatively concurrently, which is a very unusual event in amyloid. Usually the cardiac response is out of phase to the hematologic response. Now, we believe that these data are important. We believe that DARA may enhance anti-amyloid antibody therapy because of its impact on T-cell subsets. And also would urge interested pharmaceutical companies to consider dual antibody therapy for patients with AL, because these were very sick patients, and yet they tolerated 2 monoclonals. And so we come to future therapies. Dr. Zonder didn't mention anti-BCMA immunotherapies, but I think they're going to be extraordinarily important for AL patients. He did mention clinical trials, and it is my hope that Belmaf will be available in a clinical trial next year, thanks to the efforts of a small group of investigators and collaborators at GSK. One of the interesting aspects of the murine models I mentioned was that BCMA correlates with flux and light chains, and that's what that graph shows, the correlation between BCMA and kappa light chains in the mouse model. The image on the right is Belmaf, which is an antibody-drug conjugate. On Monday evening, Dr. Gadar from our group will present our data on BCMA and AL. BCMA is found on the membrane of AL plasma cells. Soluble BCMA can be measured in the serum. You can modulate BCMA on the surface of AL plasma cells with gamma secretase inhibition. And when you do that, the amount of soluble BCMA in the supernatant in vitro goes down. So we're very hopeful that this agent will go through the clinical development process and be available to us within 2 years. And you can envision a treatment plan that might include dual monoclonal antibody therapy up front or in patients with refractory disease in the future. And finally, what about these circulating culprit light chains? There's no maintenance therapy for AL. In another poster that Dr. Gadar will present on Monday evening, what we show is that the current response criteria for AL are probably outmoded and in need of revision. Particularly what we show in a cohort of 133 patients who achieved VGPR between 2006 and 2017 is that long-term survival in 42 patients who had involved free light chains below 10 milligrams per liter for any durable period, a month, 2 months, 3 months, the median was about 3.5 months, had 95% survival at 10 years. And not all of them had achieved CR. About 20% of them were VGPR patients. The rest of the patients had a median survival of 10 years. So when you look at this disease, you have to keep in mind, as Dr. Zonder suggested, that in patients, for example, with renal failure, if the involved light chain isotype is elevated, there's probably some culprit light chain there that's causing progression of disease. Don't forget, when we reduce the light chain culprit, we slow the progression of disease. But that doesn't mean that we necessarily stop it. So I do believe that the monoclonal antibody that's being developed may provide an effective agent maintenance. We've done surface plasmon resonance testing, which you see here. We have shown in vivo activity in our mouse model, which we'll present in Tarragona in March. We're humanizing the monoclonal, and we're testing it in vitro against patient samples. The goal would be to use it not up front, but in maintenance to markedly reduce the level of the culprit light chain isotype. So this satellite symposium documents the great interest in amyloidosis, as Dr. Grogan has indicated. There are multiple new classes of agents. There are suppressors, stabilizers, scavengers, RNA interference agents, monoclonal antibodies, and small molecules like AG10, which will likely be very important. And all of those classes attest to the golden age that we're now participating in. I might call it an apple-green birefringent age in pharma, but it's certainly a golden age for patients and for the physicians who struggle with this disease for decades. And as Dr. Grogan suggested, this is just the beginning. The RNA agents that are being developed in second generation are different. They don't have to be dosed as frequently. And they're being developed, we hope, for other types of amyloid. Monoclonal antibodies are being tested against other cell surface proteins and will be, I suspect, developed for other culprit amyloid proteins. The lab-based technologies are important as well. The use of next-generation sequencing for organs that are affected by amyloid, I think, should be front and center of things that we're interested in, because we have to come to an understanding of the processes, as Dr. Zonder suggested. What's the effect of tissue displacement by amyloid? Is there a potential ischemia going on in small vessels? What actually triggers the fibrosis that we see in the organs? And we need to have much better understanding of the pathogenesis of organ disease. Robust patient advocacy organizations are extremely important. The Amyloidosis Research Consortium held a patient forum in Washington, D.C. early last month, showing the interest and the willingness of the regulatory agency to engage in the conversation with pharma. Very important benchmark. And finally, I do have to thank our cardiology colleagues, not only Dr. Grogan, but Dr. Dorbala, Dr. Falk, Dr. Ruberg, and Dr. Maurer, for all of their efforts in cardiology. It's inspirational to see the efforts that are being applied to control that wild west out there of PYP scanning, as Dr. Grogan suggested, for patients with HFpEF. Finally, thank you for listening to me this morning. And please join me in committing to earlier diagnosis of these patients and novel clinical research. And I'd like to thank those who've supported the work I described and the organizers again for letting me speak this morning. Thank you. It is my great pleasure to introduce Dr. Landau, who, as many of you may know, was one of the ASCO Women of the Year a short while ago, and it's been a privilege to work with her. Dr. Heather Landau from Sloan Kettering.
Thank you, Ray, and thank you for the organizers for inviting me to give this talk today on assessing organ response in AL and TTR amyloidosis, evolving concepts. I think I joined Stefan saying that this topic has been given to me because there is not a lot of supportive data, and it is really an evolving and difficult, challenging topic, especially in TTR. So I'll start with a case presentation. A 46-year-old male was diagnosed with AL amyloidosis in October of 2012 after presenting with cough and fatigue. Initially, he was treated for bronchitis, but then developed lower extremity edema and was eventually sent for an echo, which showed increased alveolar wall thickness, global hypokinesis without distinct wall motion abnormalities, and he underwent a cardiac catheterization showing normal coronary arteries, a decreased ejection fraction, and high LV filling pressures. Fortunately for him, he developed acute abdominal pain, which led to a colonoscopy, and random biopsies of the colon showed a Congo red positive amorphous material with apple-green birefringence consistent with amyloid, and that was how he ultimately was recognized to have this disease. He was sent to a hematologist, and initial studies showed an elevated free lambda light chain, elevated NT-proBNP and troponin. So ultimately, he was diagnosed with Mayo cardiac stage 3A, revised Mayo stage 4, and had New York Heart Association class 2 heart failure. He was treated with Cybor-D for 7 cycles and achieved a hematologic CR, but developed painful, debilitating neuropathy, and his NT-proBNP remained elevated over 3,000. He sought care. He sought other options, and he actually found us and was enrolled on the phase 1/2 trial of the antifibrillar agent NEOD-001 that Ray just told you about. When he came to us, he was about 10 months after achieving a CR. On the x-axis is the percentage change in NT-proBNP versus time, and at CR, his NT-proBNP remained over 3,000. It was almost about that at the time he enrolled in the clinical trial. He was on the phase 1 portion, and his NT-proBNP started to trend down. When the recommended phase 2 dose of 24 milligrams per kilogram was defined, all patients were changed from the phase 1 portion to the phase 2 portion and offered this dose, and he continued to have an NT-proBNP response. My slide of my questions did not come up, but my question about this case to the audience is, so what was the reason for his improvement in his organ function? Number 1, was it his achievement of a complete hematologic response due to CyBOR-D? Was it 2, the antifibrillar antibody NEOD-001? 3, was it going to a doctor and getting put on who understood amyloid and getting put on diuretics rather than beta blockers? Or 4, all of the above? And I think I'll leave you with that question while I continue the talk. So as we know, AL amyloidosis, the pathogenesis is because of a dangerous small B-cell clone that produces the immunoglobulin, the heavy chain and light chain, and it's these light chains that Ray just told you about that are either kinetically or thermodynamically unstable, and due to cellular and extracellular interactions form these amyloid fibrils and disrupt organ structure and function. And we do know that different germline gene usage predicts different organ tropisms, but the most important determinant of survival is having cardiac involvement. So we know that light chains from patients with AL cardiomyopathy induce MAP kinase signaling and increase production of reactive oxygen species, impair calcium homeostasis, and this is what leads to eventual cardiomyocyte death. We also know that MAP kinase signaling is responsible for transcription of the B natriuretic peptide, and this shows a direct link between the toxic light chains that cause cardiomyopathy, MAP kinase signaling, and elevated BNP in this disease. And it's not surprising that both BNP and NT-proBNP are prognostic markers in AL, and troponin, which is also a marker of cardiomyocyte death, also independently is associated with survival. And the initial cardiac staging system based on NT-proBNP and troponin devised by the Mayo group, which was further revised by the the UK researchers, which better discriminate outcomes in the highest risk patients, is the most useful, most commonly used staging system, both in clinical trials and in clinical practice. And the figure on the left shows data from about over 1,000 patients from PAVIA, discriminating the patients' differing survivals based on this staging system, whereas the figure on the right shows data from over 900 patients from the UK group. And what can we say about this? Maybe we can say that Ashu treats his patients better than Giovanni and Giampaolo does, or we can just appreciate that actually the figure on the right is from a more contemporary cohort where there is access to more and emerging therapies that we've already heard about this morning. But we can also appreciate that our stage 3B patients over time in this contemporary cohort, the outcomes have not changed for these patients, and our most advanced patients, our sickest patients, are not benefiting from any of these emerging therapies. We're also grateful to Dr. Sancharawala for developing the BU staging system, which is based on both BNP and troponin, because not all centers have access to NT-proBNP, and this is an important staging system. And we can also understand that the clonal burden of disease as defined in the revised Mayo staging system as assessed by the serum free light chain assay, or the difference in the serum free light chains, which was incorporated because it's also an independent prognostic feature, is also useful to define our patient population. We have emerging technology, or we have appreciated that 2D global longitudinal strain, which is a very sensitive technique for measurement for it not only is important for diagnosing patients with amyloidosis, but also predicts survival in transplant and non-transplant patients. But it has to be appreciated that there's different platforms for analyzing strain, and these cut points and these survival differences really need to be interpreted within a context. We have a staging system for patients with kidney involvement who are at risk for developing end-stage renal disease, as we heard from Dr. Sancharawala, and based on the 24-hour urine total protein and GFR values. And patients with stage 1 disease really have a low likelihood of requiring dialysis, but our stage 3 patients have a 50% risk of requiring dialysis at just 2 years. How do we treat the disease and improve organ function? Right now, all of our therapies have been, to date, directed at the plasma cell, and with elimination of the pathologic plasma cell, we see reduction in the free light chains, and when we achieve hematologic response, organs can improve, as indicated by the biomarkers that define the organs. And if we achieve a hematologic response, we can prolong survival. But if we achieve also an organ response, we improve that significantly more. We are fortunate to have validated criteria for assessing hematologic and organ responses in cardiac and renal patients. So hematologic response is based on the serum free light chain assay, and we're grateful that the low DFLC response has been initially studied in patients who didn't have measurable disease and predicts for a better outcome in this group of patients. We also have validated criteria for assessing cardiac response, which predicts overall survival, and renal responses, which predict for renal survival. Have to appreciate that we don't have any validated criteria for hematologic progression in this disease. So we don't know, and it has never been studied, at what level of free light chain causes organ progression. However, we do think that minimal assessment of minimal residual disease will be a critical factor for understanding the risk of organ deterioration and also for organ response. And these data from the Pavia group in 69 patients have shown that patients who achieved a MRD negative disease by next generation flow cytometry have a higher likelihood of achieving an organ response. However, this relies on bone marrow testing and assessing the plasma cells, and it is likely that detecting minimal residual disease by clonotypic light chains in serum or urine will be more useful in this disease as opposed to bone marrow-based testing, which has been useful in multiple myeloma. And indeed, Dr. Dispenzieri has shown that in 53 patients that at complete response by IFE, free light chain, and 6-color flow cytometry, 4 of the patients were still positive for the original clone by mass spec-based technology in serum. And I call your attention to Dr. Sharpley's presentation on Monday, which also shows mass spec techniques can be really sensitive for detecting residual disease in this in AL amyloidosis. While mass spec techniques are not yet ready for prime time, we have heard the value of reduction in the DFLC to less than 1 milligram per deciliter, initially studied again in patients with a low free light chain burden, and gives us a tool for measuring responses in this patient population with favorable overall and renal survival. And in over 900 patients, we're now fortunate to know that in 900 patients treated with bortezomib-based therapies, independent of whether they had low free light chain burden or measurable disease, a reduction in the DFLC to less than 1 milligram per deciliter was associated significantly better overall survival, time to next therapy, and progression-free survival, and even increased the frequency of cardiac responses. Again, I'll bring your attention to an abstract from Dr. Purvey showing the value of achieving a prompt DFLC less than 1 milligram per deciliter, which predicts for early renal responses, and and as well as the other data from Dr. Comendo's group that will be presented at the similar session. We also have retrospective data dividing responses for organs based on 4 categories, a less than a 30% that have been published, less than 30% reduction in these parameters, NT-proBNP, proteinuria, or alkaline phosphatase in patients with hepatic disease, constitute no organ response, a 31 to 60% reduction, or a partial organ response, and greater than 60% reduction as a deep organ response, and below a certain threshold as defined by these investigators as a complete organ response. And these authors have shown that grading the depth of organ response is a better discriminator of patient outcomes, and we look forward to an international effort to validate these findings, which is currently ongoing. GLS, which we've heard about this morning, is a good predictor of overall survival when looking at baseline characteristics, but it has also been studied by several groups over time, and serial values from our group in 34 patients with advanced stage of amyloid has shown that patients who have a hematologic CR can have improved GLS, which is really a function of our first functional measurement that has been appreciated in our. Sorry, this is 34 patients who 9 of whom had achieved a CR following transplant, and not unexpectedly, the BNP has decreased, the troponin has decreased, but this was our first cohort that showed that the GLS can actually improve, which is distinct from patients who did not achieve a CR. In summary, assessing organ response in AL amyloidosis is achieving an organ response in AL amyloidosis is unlikely to occur in the absence of a hematologic response, and is definitely dependent on the depth of hematologic response. We also have to appreciate that organ responses evolve over time, and I'll show you a scenario where this is important. Historically, our organ responses have been based on cardiac biomarkers and 24-hour urine protein excretion, but we're looking forward to new information on refined depth of organ response, which will be likely be better discriminate patient outcomes. We also are looking forward to more data on echo parameters such as global longitudinal strain. I didn't speak about MRI characteristics, which we do know again can be prognostic in the as baseline criteria, but haven't really been studied in any robust way over time. Other imaging that may come to the forefront is floor beta peer PET, which is a much more sensitive test of amyloid load. One question that I'll ask is, will the same biomarkers apply with the use of fibril-directed therapies? And I think that incorporating these into the studies that are upcoming will be very important. I'm moving on to transthyretin amyloid. Dr. Comenzo explained that transthyretin is produced by the liver. It circulates as a tetramer, but it's when these dissociate and the monomers misfold and become misfold into into amyloid fibrils and deposit in the heart and the nerves that patients get sick with this disease in both the wild type and hereditary versions. Fortunately, we do have some staging systems, as in 2016, Dr. Grogan published a staging system based on troponin and NT-proBNP, which can discriminate patient outcomes, and in wild type TTR. And in 2017, the UK group published a staging system based on NT-proBNP and GFR in both wild type and hereditary cardiomyopathy patients. And but we have to understand that although these biomarkers are useful and are being incorporated into clinical trials in wild type and hereditary TTR trials, there's really limited data for validating their use for either response or progression in these diseases. Serum transthyretin has been studied as a prognostic indicator in wild-type TTR in over 100 patients, and a low value of TTR below 18 milligrams per deciliter versus a higher value was predictive of overall survival in this small cohort. And these investigators showed that in a small number of patients who were treated with diflunisal, the stabilizing agent, the serum transthyretin could increase. And the authors suggested that this may be useful as in order to determine as a determinant of organ response or progression. However, with the use of RNA silencers, as Dr. Comenzo just alluded to, that serum transthyretin, the role of serum transthyretin will be evolving and probably not useful in that cohort with that therapy. So assessing organ response in TTR is really a black box. In the absence of available therapies, there really has been limited data characterizing organ responses in this disease. There's emerging disease-modifying therapies for TTR, and with the introduction of these therapies, there's really a critical need to study these biomarkers as surrogate endpoints in research and to guide treatment efficacy in clinical practice. Going back to our case presentation of our gentleman who achieved a complete hematologic response but still had elevated cardiac biomarkers, we look at his assessment of treatment response. Pre-treatment, he had an NT-proBNP of 3,000, over 3,000. Post-treatment, this has improved considerably, and he has achieved a documented organ response. He also has had an decrease in his ventricular septal diameter, an improvement in his ejection fraction, and a marked improvement in his GLS. That being said, the answer to the question whether or not this is because of achieving a complete hematologic response, because of receiving antifibrillar antibody therapy, because of being put on diuretics, or all of the above, I still don't have the answer to that question. One last concept I think is important when talking about organ responses is that organ responses evolve over time. Here we see a patient whose free lambda is on the x-axis. Free lambda is shown here, and this is a patient who in 2008 underwent a stem cell transplant. You can see that unfortunately she had no response to her stem cell, no hematologic response to her stem cell transplant, but after BD consolidation, 6 doses, she achieved a prompt hematologic response, but of course developed debilitating neuropathy as we were giving IV bortezomib at that time. And in 2019, she has not received any other treatment and has remained in a complete hematologic remission. At baseline, she had 21 grams of proteinuria. And what you can see here is she achieved a complete hematologic response in 2008. It really takes a long time for organs to improve. She achieved a level of less than 1 gram. Again, she had her hematologic response in 2008, and it wasn't until 2014 till she achieved a urine protein excretion less than 1 gram. And in 2019, it is no longer detectable. And what you could also appreciate is her serum albumin level, which was in the 1 range when she was diagnosed, took 4 years to become normal. So the conundrum is you achieve a hematologic response, but you still have this very high urine total protein, and oftentimes I see patients who are continuing to get further therapy, even despite getting side effects from therapy because this organ biomarker has not improved. And sometimes it just takes a little patience. Hopefully with antifibrillar therapy and the studies that are going on planned by Dr. Lynch and Kalem Biosciences will help speed organ recovery. But again, I think right now assessing organ response with those therapies is still really a black box. I thank you for your attention. Coming to New York, visit us in our new building. I really want to thank the organizers, Jeff, the amount of work that Jeff and Silva particularly have done to make this symposium available to all of you, not only all of you, but all of the doctors and patients and interested parties outside of this room is really commendable. And we really, I want to thank not only my colleagues and collaborators at MSK, all of my collaborators here on the podium, and really the amyloid community, which is really a very tight-knit community, all working towards the common goal of identifying these patients earlier, getting them treated, and really stopping the progression of this disease.
Okay. Thank you. So I think it's either a testament to the high quality of the talks that we had or to how early the symposium started, that the room is much fuller now at the end of the lectures than it was at the beginning of the lectures. But I think it's the first thing, because these were really great talks. And one more quick round of applause for all the speakers here. Really thoughtful presentations. Now, for those of you who are who've been logged in and following the sort of the question stream, we've gotten many questions over the course of over this symposium, directed at basically all of the speakers. And I have the opportunity to see which ones sort of garnered the most thumbs up, so that the ones that I think the audience are most interested in. So I think we'll start with those because they're pressing from your standpoint, and then I'll pick through some of the other questions in the remaining time that we have. We have about a half hour, and we'll cover everything that we can. I'm apologizing ahead of time. We don't have time to answer all the questions that were asked. So the first question that got the most, that generated the most interest is, I think goes back to the first talk of the day, is which patients with AL amyloidosis should not be considered for upfront transplant? What?
So again, I think that I would need this microphone, please, because I just fell off.
Yep.
Yes. So again, I think the eligibility criteria for stem cell transplantation in patients with multisystem AL amyloidosis vary from center to center and the experience of the centers. At my institution, newly diagnosed patients with AL amyloidosis without prior treatment who come to BU amyloidosis center, the 20 to 25, maybe 30% of patients are eligible to get stem cell transplant. So majority of the patients are not eligible to receive stem cell transplant. So again, it is not for everyone. Patients with significant heart involvement, poor functional status, systolic blood pressures less than 90 are definitely not eligible to receive stem cell transplant. And that is really, this is really in a highly selected patient population. Furthermore, with advent of new therapies and novel agents, I think that if the patient is borderline for stem cell transplant eligible, then I think we would rather err on the side of doing non-stem cell transplant regimen first and offer stem cell transplant when organs have recovered better or if they've not achieved a response.
Can I ask a follow-up question to that maybe to both of you or anyone else on the podium? For patients with an 1114 translocation who have not responded adequately to first therapy, or whatever that is, not non-transplant therapy, do you stretch or change or do anything, do any other considerations with regards to transplant eligibility for that patient subset?
So we do have a subset of patients when patients were treated with CyBorD in the community for 1114 translocation and did not respond after 3 or 4 cycles, and then they are sent to us. If they are eligible from other perspective, we would offer them stem cell transplant or at least a melphalan-based treatment.
I would say it's also a matter of how high the DFLC is. So is there another attempt possible to lower down to get a response before transplant? So if there's a reasonable way to do it, we would also offer these to the patient, like lenalidomide or now DARA.
One question that came up in the stream, again, for any of the transplant physicians here, how do you select dose, melphalan dose for your patients? How do you decide when a patient isn't suitable to get 200 milligrams per meter squared?
So, historically, we have been using a risk-adapted melphalan dosing system where patients are getting MEL 200 if they're over sick, if they are based on advanced age, renal involvement, and cardiac involvement. So anybody who is over 70 or has a EGFR less than 50 or cardiac involvement stage 2 or greater is reduced to MEL 140. Now we have an exciting clinical trial where we're using PK-directed melphalan-based dosing, where we give a test dose and we target an AUC based on Australian data of 13.5. So we do really personalized melphalan dosing, and we've included about 10 amyloid patients in that cohort where we don't necessarily reduce the dose based on the patient's clinical characteristics, but we use their AUCs to guide PK dosing.
I could see how that would be useful for reducing the dosing in renal insufficiency patients, right? But patients who you're reducing the dose for because of their frailty, should we still be shooting for the same AUC, or should we?
We don't know. That's why we're doing the trial.
Mm-hmm. Does anyone?
But I can tell you that the patients who achieve that AUC that has been shown by the Australians to be really the quote-unquote sweet spot have done quite well.
Anybody
and
else?
probably frailty are not the patients who are being selected for stem cell transplant.
Does anyone else have any comments on that topic?
Yeah, I do want to congratulate Heather and Vaishali and others who put together their experience with patients transplanted with MEL 140. It's an interesting option that may be of some use in patients who achieve good responses to CyBorD after 4 or 6 cycles. I don't think we've taken enough of the myeloma experience to heart. The myeloma experience is induction, show responsiveness. In the modern era, it's optimal response, and transplant. And I do think there are many patients who'd be spared the recurrence of disease at 2 years, 3 years, 4 years after CyBorD had they been consolidated with transplant. And MEL 140 is extraordinarily well tolerated and almost as good as MEL 200 in many instances.
Something that we didn't really touch upon at all today, but which I think is a common scenario, is our treatment strategy with regards to induction therapy and or stem cell transplant different for patients with IgM AL amyloidosis?
it's a difficult one, I think. It's very rare, but and it's a problem to treat these patients to really achieve a remission without a stem cell transplant. So the pressure to treat these patients with a stem cell transplant is higher actually than the normal AL patients. So that would be my comment to this.
So IgM-associated AL amyloidosis has been reported by multiple groups, including our groups from UK, from Mayo Clinic. The most recent publication was from the Mayo Clinic group. I don't know if Surbi is in the audience or not, but she was the first author on the paper. And they divided IgM-associated amyloidosis into two categories of lymphoplasmacytic lymphoma, so like Waldenstrom's associated AL, versus pure plasma cell neoplasm associated AL. And again, I think what was really different in this paper was that patients who had LPL-associated or lymphoplasmacytic lymphoma-associated AL did receive treatment which was similar to Waldenstrom macroglobulinemia-like treatments, like Rituxan, bendamustine, and other treatments. Whereas patients who had pure plasma cell neoplasm-associated IgM AL amyloidosis were treated more as AL amyloidosis. So we, generally speaking, at my institution, do transplant these patients. And actually, in our cohort of patients, they have done remarkably well, even better than AL amyloidosis, with the relapses are really, really low, or that we've not really actually seen any relapses.
Yeah, I think the message has gotten through to the Waldenstrom's community, too. If a patient is diagnosed with Waldenstrom's and has AL, it is worth considering stem cell transplant as part of that induction therapy. Many Waldenstrom's patients, after all, 10 to 15% develop AL. Many of them develop later in the course of disease after they've been rather heavily treated, and it's complicated to offer stem cell transplant in that circumstance. But early on, stem cell transplant can provide a significant benefit. I totally agree with Vishali. The responses are really dramatic and quite durable.
We have a few questions focusing on cardiac issues. One, I think, is a very common one. Can you comment on the relative value of and use of NT-proBNP versus BNP in terms of tracking patients, pros and cons of each marker?
Obviously, the biggest issue is that some centers have one versus the other. So there's not a formula where you can completely where you can change from one to another. So I think really it's following the baseline with whatever technique you have, and labs can argue about why one versus another, but whatever one you have, following that one serially. And I think as Heather showed with her patient, or when you're looking at BNP or NT-proBNP, you do want to look at the overall trend, because you can get spikes very easily. If somebody goes into atrial fibrillation with rapid ventricular response, NT-proBNP can skyrocket, and doesn't mean that the heart got worse. If you look at the trend over time, that's the most effective. Important to recognize, despite the fact that there are the criteria for organ response, is that it is known that BNP, NT-proBNP both can vary about 40% over a week in a patient who is completely clinically stable with just general heart failure. So I try to explain to the patients that we're really looking at the baseline and we're looking at the trends. And as we all know, our patients who plot things and they want to know if they're getting better, that's very difficult until you have the longer term follow-up, as Heather showed us. I think you really are limited to using the one that you have in your center.
Another cardiac question that came up, it's actually kind of two related questions, particularly in the United States, where cardiac ATTR dominates more, I think, than over neuropathic types, due to the predominance of wild type and also the Val122 isoleucine subtype. Because a significant subset of those patients will have MGUS as they get older. 5 to 10% of patients, right, in their late 70s and early 80s will have evidence of a monoclonal gammopathy. according to the algorithm that we discussed, where you do blood testing to make sure that you can trust the results of the PYP scan, how do you trust those results of the PYP scan in terms of differentiating between AL and ATTR? And is that a patient subset, who has to have a cardiac biopsy to distinguish? And as a second question, are there other? Can you talk about other situations where cardiac biopsy actually probably needs to be done to make the diagnosis?
Yeah, so great question. And for those in the audience who might not know, for especially wild-type TTR, the yield of non-cardiac biopsy is relatively low. Fat aspirin is about 15%, but it is 15%. So if you have an experienced center with good fat aspirin, you should do it. If you add on a bone marrow, you'll get up to 35%. You'll get a little bit more. Heart biopsies, are not benign procedures. So although the overall risk is relatively low, there are potentially serious complications. Most serious one, of course, is death due to perforation. That's pretty rare, but it does happen, or a need for emergency cardiac surgery, or disruption of the tricuspid valve, leading to severe tricuspid regurgitation. So that's one of our challenges. True amyloid patients are at less risk because the right ventricular wall is usually thick, so a little less chance of perforation. But especially, of course, when we didn't have treatment, just to diagnose a disease for academic reason, not as important. But back to the MGUS. So in the studies of patients who were diagnosed with wild-type TTR during the era where biopsy was required, 30 to 40% of those had an MGUS. But of course, they were selected patients who were getting tested. So it is a high percentage. What we're preaching to the cardiologists is they really need to do the serum free light chains, the serum and urine immunofixation, and they need to work closely with the hematologist. And really, you are going to use other factors. So you're not going to biopsy every single person that has a slight abnormality of free light chains. But if they truly have a monoclonal protein, you cannot use the PYP scan alone. So you decide who needs a cardiac biopsy. Now, if you have a 90-year-old patient, bilateral carpal tunnel, spinal stenosis, every single thing, maybe there's a little monoclonal protein, but you still really feel that it's TTR, you might not biopsy them, but most of the ones that are not in that category. So one trick that I've used with these wild-type patients, I look for any tissue that they had anywhere. So did you have a prostate? Oh yeah, guess what? 4 years ago, TTR in the prostate. Bladder is pretty high yield. Spinal stenosis, I put that in to be provocative. Now that was 45% wild type, not 100, but we don't know what it's gonna be, but it's, or the patient comes to you, they have active carpal tunnel. Then you can send them to the hand surgeon and say, take some of that tissue and get it for me. So I do think heart biopsy definitely still has a role. You want to make, not all centers actually are adept at doing heart biopsy. So if you're outside of a heart transplant center, they're not done as well. So you may make sure you get somebody good and biopsy them. But if they really have a monoclonal protein, you cannot use a PYP.
Yeah, I think Martha's 100% right on most things. We're a little more biased towards heart biopsy in patients that come to us who are symptomatic and perhaps had not had a good experience with a beta blocker and have a positive PYP scan and have an IgA lambda in serum immunofixation and lambda light chains of 50 or 60. We don't routinely recommend cardiac biopsies if we think we can get away with a fat pad, but in many instances the fat pad's negative. So we try to serially track things, simultaneously track things as opposed to doing them serially. So we'll send off the TTR gene test. We'll arrange for the heart biopsy. We'll do the fat pad aspirate. If the fat pad aspirate is positive, you really have to know how much amyloid is there, because it may be untypable because there's too little amyloid there. We do go back over prior biopsies that may have been obtained in the patient. You can't, of the 60 or so cases, and Dr. Gadara knows more about this than I do, who had amyloid in their ligamentum flavum. There was somewhere around 10%, 15% that had amyloid of indeterminate type. So even the ligamentum flavum, when it has amyloid isn't 100% useful. So we take all of those factors into consideration, but we have a low threshold as a rule to obtain a heart biopsy if we need to know what to do for the patient in a timely way. Typing can take 2 weeks, and it's often a struggle, and you want to be able to have some certainty with the typing, but typing is not 100%, depending on the amount of amyloid that's present in the tissue that's offered.
We really do agree. Just,
Yes.
just to clarify, actually, in our case, we get fat aspirate the day before I see the patient. I'm going to have it at 12 o'clock that day. And so I can decide, do I want to do a heart biopsy that afternoon? So it's done very, very quickly. It's pretty low yield in the wild type. But if you have it and you get AL from there, you might save the patient a heart biopsy. But again, we preach to the cardiologists that the consideration of amyloidosis is a medical emergency because you do not know if it's TTR or AL, and guessing is not good. And we didn't touch on the fact that there are patients that can have more than one type of amyloid, all these exceptions to the rule. So the more that you see, the more you get paranoid about maybe this patient is the exception. So we tell cardiologists that I made this rule, no data, but you have 1 week to get all your tests. Now, you might not have the typing, but you need to get all your tests. So that would include, if you're going to do a biopsy, this does not stretch out over 18 months. This has to be fast. And I'm sure that many of you, if everything is consistent with AL, you often may consider that you're going to treat the patient before you get the final typing result. So we certainly have done that. So the problem has been that for cardiologists, this has been either a fatal disease or an academic disease. Now they really, truly, our sessions are completely packed with people wanting to learn about it, but they're getting very, very confused about the screening for AL, and we recognize that many hematologists who are not amyloid experts are often confused about it too. So.
The next question has to do with stem cell mobilization. And I was wondering if anybody on the podium could speak to the potential complications that occur in amyloidosis patients during mobilization, and whether patients with advanced cardiac amyloidosis are handled differently during that period.
I could say I learned from my mentor to the left of me, Dr. Comento, that patients with either autonomic dysfunction or advanced cardiac disease really have difficult times with fluid shifts, hypotension, arrhythmias, and any patients with those characteristics are mobilized in the hospital on telemetry. We don't use cytoxin mobilization. We use G and plerixafor for all of our patients. And I usually use it as a stress test, actually. So patients who have a difficult time with their mobilization will have a very difficult time with their transplant, and it may be a useful consideration to think about alternative strategies if they really have a hard time during their stem cell mobilization. Patients who you think may have a hard time during their stem cell mobilization, but then prove you totally wrong, and really their hospitalization is boring and without any blood pressure, fluid retention issues, usually predict for a very much easier than expected transplant course.
We also use that term, I mean, from a cardiac perspective, it really is a stress test. So I think you want to be cautious. Obviously, if you're going to be harvesting, it's because you think the patient is a potential candidate, but they do declare themselves. We try to follow the patients very closely around that time with a nurse practitioner who's very used to the fluid shifts that may occur, the arrhythmias, try to manage these things early. But when we see that, we know that's a red flag. Now, sometimes patients later on may improve, and later on they may go on to have their stem cell. But the other thing I'll say about stem cell in general, you asked that question in the beginning, is that although I think the criteria may vary a little bit, we know that NT-proBNP of greater than 5,000, the troponin greater than 0.06, the blood pressure less than 90, pretty standard criteria. There are a subset of patients that are within that threshold who are sicker than they seem to be. So again, numbers are great, but they're not everything for a variety of reasons. And so if you see a patient that's struggling or has heart failure out of proportion to their biomarkers, those are really red flags.
Can I just ask a question and follow up? Why G plus plerixafor for all patients? As opposed to just G? Is there a difference? Does it permit a difference in dosing, or?
It just minimizes the time to, it's just very effective at minimizing the need for multiple apheresis sessions.
And also, I think the dose of G is lower when it is used with plerixafor at 10 mics per kilogram versus when it is G alone, which is 16 mics per kilogram. So I think the fluid retention properties and capillary leak associated with high doses of G is lower. So at BU, for all cardiac involvement patients, we use G plus plerixafor mobilization, whereas for stage 1 cardiacs or renal only, we use GCSF alone. And we use plerixafor also on demand for those patients, not as planned. Also, one other thing about the MGUS and wild-type TTR, which we were talking about earlier, as Jeff is scrolling down all the questions, is that in our series, there were 39% of patients with wild-type TTR who had monoclonal gammopathy of unknown significance, and majority of them were biopsy-proven. Of those 39% of patients, 95% had IgG kappa or kappa. So when you have a lambda monoclonal gammopathy, always be careful, because then you might be dealing with AL and not wild-type TTR. Furthermore, V122I ATTR mutant amyloidosis, which is common in African American patients, they have a higher risk of MGUS. And in our series, there were 50% of patients with V122I who had monoclonal gammopathy of unknown significance. So again, I think nuances of this disease are such that experience is absolutely critical. And I think if there are any questions about diagnosis, do not start them on treatment. Please refer them to experience centers.
Tafamidis, you mean, or on TTR treatment. I do think we will probably be seeing more heart biopsies. So heart biopsy has been usually done post-transplant for rejection for certain types of myocarditis, although really mostly if we think there's giant cell, it's had a lower role in recent years. So I actually think you will see more heart biopsies, which is not necessarily a bad thing. A quick question I have for the panel, because I've been shocked at this issue that I found out from my colleagues, that they order serum protein electrophoresis with immunofixation. That's what they put on their order at their institution. But then they only get it, immunofixation, if the SPEP is abnormal. So I did not realize that that was very common, but it is common. So it's common at fairly major medical centers. I think those of us who are at amyloid centers are so spoiled, we do not know this. So this is a huge problem, because the doctors read the consensus statement and it says you need to exclude a monoclonal protein. Okay, we can agree they really should do urine, but we really want them to do the serum, right? So they do the serum-free light chains and they order everything that we tell them to order, and they get a result back that says no monoclonal protein. So, they think that they're done. Again, most of the time the light chains would have bailed them out, but not always. But I've just heard from one of my former trainees who's at a pretty major medical center that he just had to fight with the lab director just this week, so that when he orders it, he'll really get it. So I don't know, but I figure you're all here at ASH and you must have relationships with lab directors and do something, but it's actually not a minor problem for cardiologists.
Okay.
I think you're absolutely right. I've been very fortunate to be able to order them both and get them both, and we do that routinely at Tufts in large measure because B.J. Magnani moved there in 2008 and has a real interest in the plasma cell diseases. But there are pathology services that view the immunofixes as labor intensive. The labor component is not small, and therefore they don't do them routinely or reflexively if the SPEP is negative. I am hopeful over time as mass spec, which is I think going to be beta tested next year by the binding site, as mass spec comes into the arena of clinical laboratory tests, it will take off because it's less labor intensive in the laboratory and provides you with quantitation. And that may indeed be the only solution to this problem, because the older clinical pathologists are sticking to CAP guidelines which call for reflexive testing.
What we see is a patient has 2 or 3 echoes, maybe 2 or 3 heart caths, and then finally we get this simple test that could have led us to the diagnosis.
I think we have time for one more question, and then we're going to wrap it up. Before we go over this question, I just want to remind everybody to do the evaluations for the program. Turn them in. They're necessary to get your CME credit. Please, please, please do the evaluations. Plus, if we do this again in the future, we want to know what we did right today, and we want to know what we did not do right today, and that's important feedback for us. Last question by Shelley. I'm going to start with you, but this is really a question for everybody at the table. During your talk, you mentioned data about patient attrition during bortezomib induction, which reminded me of old data you generated using melphalan before, when what we had as an induction option was melphalan and prednisone before moving to transplant, and the data actually seemed the same in a way, that we lost some patients. Patients who started as potentially transplant eligible became ineligible over the period of time that they were getting induction. So the two topics I want to sort of finish with are, one, those patients that we lose or who slide out of transplantability, is it, in your experience, mostly due to induction toxicity, or is it mostly due to progression of amyloidosis or a complication of amyloidosis while we're waiting to get to transplant? That's A. And then the second question I have is, so when using induction therapy in a transplantable patient, in your own practice, do you simply use it until you get the patient to transplant as fast as possible, or do you use it for a prescribed period of time, a certain number of cycles, and with the plan to move to transplant like we do in multiple myeloma? I'm going to open it up to everybody.
So I think, induction therapy can be considered as a stress test too. If you cannot handle induction therapy, it is unlikely that you're going to be handled stem cell transplant. Furthermore, I think all the trials that I did mention in my talk, which was one of our trials, HO1 trial, as well as the Chinese trial, the bortezomib was given as twice a week. So again, with Cyborg-D or once a week, maybe the results might be different for patient attrition during induction therapy. At my institution, we do offer induction therapy for patients who have plasmacytosis of greater than 20%. Those patients do get induction therapy once a week, bortezomib, Cyborg-D, and for a limited number of cycles, whether 3 or 4 cycles followed by stem cell transplant. If patients do achieve a complete hematologic response after 4 cycles of Cyborg-D or 2 cycles of Cyborg-D, I generally do not perform stem cell transplant, as I have said it very kind of crudely, that I don't want to kill anybody in hematologic CR during stem cell transplant. But that's my viewpoint.
So our cutoff is 50 milligram per liter DFLC. So below that, we also offer direct transplant, and then we do the myelinization with cyclophosphamide, also to have a chemo stress before. And the other way around, if you have a patient with 200 milligrams of a DFLC, we want to see this patient after 1 or 2 cycles. And then we can see what is the toxicity and what is the likelihood of remission, and then we make this the decision how fast we go to transplant. So that's our approach.
So this is funny. We use a cutoff of 10% plasma cells in the marrow. Patients who have more than 10% plasma cells in the marrow, at diagnosis, we score as multiple myeloma. We code them as myeloma because the pathologists at our institution are kind enough to put in the report consistent with multiple myeloma, which solves the insurance issues. In patients who are significantly sick, stage 3 cardiac patients, for example, we treat them with daratumumab, Velcade, and Dex. We get approval for daratumumab, Velcade, melphalan, and prednisone, and treat them with daratumumab, Velcade, and Dex to get them cytoreduced as quickly as possible. At the same time, in patients who may be transplant eligible, we start treating them with weekly Cybor-D and seek insurance approval. So they may get 1 or 2 doses of Cybor-D before they get mobilized and transplanted. I think in the literature on amyloid, it can become very confusing. The issue of induction therapy, the issue of outcome with transplant, the important issue which hasn't been raised here effectively, I think, is consolidation after transplant. We really believe that patients who have any persistent clonal disease after transplant should be consolidated. There is no maintenance therapy that's been approved for AL. Dr. Landau has a trial using exazimib for 2 years. But I do think if there's persistent clonal disease post-transplant, an effort should be made to consolidate patients. And if the patient can tolerate an IMiD in the setting of consolidation, I have no problem using an IMiD in that setting. So there's a lot of customized therapy. Where's it going to get us? Well, I do think we should come to some agreement as to when we're going to assess response. The logical thing is to try and assess response at a time point, at a year, as opposed to saying post-stem cell transplant. So we try to customize things for individual patients using all of the semantic hocus pocus that we can muster.
The last word.
I think then that that wraps up today's session. Thank you all for those of you who stuck around for the entire thing. Please feel free to come up and talk with us for a few minutes after if you'd like. Thank you again so much for everybody. Thanks to all the speakers.